Well, good afternoon, everyone, and welcome to this evening's Spondyloarthritis Forum here in Vancouver. My name is Don Bindon, and I'm the president of the British Columbia chapter of the Canadian Spondylitis Association, and it's my pleasure to be your master of ceremonies for this evening. We have a number of very important speakers coming out tonight. Some have traveled a considerable distance. There is a convention going on at the same time that we're here, and we were fortunate enough to be able to secure the place to do a free forum while the presenters were actually in town. Just wanted to let people know a couple of things. I'm going to do some housekeeping items. One of the things is that the washrooms they're on the floor, and if you notice, just around the corners in that direction, there's the washrooms. This building, if there is a fire drill in this building, there is a two-stage fire alarm system. So if the fire alarm goes off and just does ring, 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 it is not an indication that we have to evacuate the building. They're just examining a board somewhere that's giving them a light. So we won't evacuate in that case. If we get a steady ring on the fire alarm, we will exit here to the stairs on that side, and we'll meet in the front parking lot of the building if we are, and I will make an announcement for sure, and if this alarm starts to ring loudly, we will leave. This is British Columbia. We get 30 recognizable earthquakes a month in British Columbia. For those who are visiting from someplace else, if this building begins to shake in the province of British Columbia, we drop, cover, and hold, which means we get down below the level of these tables, and we grab onto something like a table leg, and we don't get up until the building stops shaking. Do not run out the door. Do not stand in doorways where you may have seen on television where it's safer. The safest possible place here is underneath this table, if you can get under it, or as close to these tables. Trust me, if you look up here to see where I am for any instruction, I will be under a table already. Because I teach this stuff, and actually I fit under the tables. At our age, by the way, we do not practice this at our age. It takes us too long to get back in our chairs, so there will be no practice. If you have your cell phones, if you could please have your cell phones go to vibrate, please, instead of to the noise. This is spondyloarthritis. If you have to stand up and walk over to a side wall and practice your occiput to wall alignments, please feel free to do so. No one will look at you sideways here in this room if you have to get up somewhere and go stand like this or any other position that you feel comfortable in when you're doing that. You will notice in your handout, first of all, there is a blue sheet. If you go down a little further into it, there's a blue sheet. And that is for the questions for our speakers. We have a question section at the end tonight. So you can write down any of your questions. There should be pens on the tables. And there is a very fine lady, Maria Morales, will come around, will be in the room, and will come around and pick up any of your questions. You can kind of hold them, and around lunchtime we'll start to collect them, and a little later on in the evening. And we will use those questions in order to allow the speakers to have some idea about what the questions will be before we go to the question and answer section. A couple of other things. First of all, this particular forum is a co-sponsored event between the Spondyloarthritis Consortium of Canada, SPARCC, and the Canadian Spondylitis Association, which is our association. We are fortunate that we have some very good sponsors that have helped put together this event and other events much like this that we hold. Those sponsors are on the orange sheet in your folder. AbbVie, Amgen, Novartis, Jensen, Celgene, UCB. These are fine companies who have helped us put together this presentation, and we thank them very much for their sponsorship. A couple of things about the Canadian Spondylitis Association, the organization that I'm a member of. We are a national organization made up of representation from across the country. We happen to be the BC chapter of that association. The Canadian Spondylitis Association was formed in 2006, between 2006 and 2007, so this is coming up our 9th or 10th year. We are a patient advocacy organization, and we are also a patient information. You'll notice that there is material that you have there on a table outside. Spondylitis.ca is the website, www.spondylitis.ca. There is a great deal of information you can have there. You can join our association for free. It puts you on the newsletter system. And you'll also hear about when we do free forums around the province of British Columbia. And we'll also try and pick up any of the forums that are being done by others besides us. We do these all over the province, and there are a couple or more that are done in Vancouver usually each year. I'd like to begin by having our first speaker come. So if I could put on my glasses, actually. So Dr. Jonathan Chan is a rheumatologist from the University of British Columbia, and the Artis Health Centre here is in private practice in Vancouver. And he's a collaborator with the Spondyloarthritis Research Consortium of Canada. And I'd like to have Dr. Chan come up and begin as our first speaker. Dr. Chan.
Thanks, Don. That was probably the most thorough safety summary I've ever heard prior to a talk. And I thank you, everyone for coming out on this Saturday afternoon. It's great to see the support of the community here. So I'm going to be talking mostly on the axial or spinal side, and down the road, Dr. Chan will be talking more about the peripheral side of things. So some disclosures, none particularly pertaining to my current talk, but I have advised and spoken for various companies there. So overview. So I wanted to highlight what is axial spondyloarthritis, what exactly is being affected, how did this happen, how do you get this, how can it manifest, how is it diagnosed, what are the pharmacologic treatment options, NSAIDs. You might have heard about TNF biologics, biosimilars. It just kind of highlights some of the newer agents coming down the pipeline there. Feel free to ask any questions. If you just put your hand up, I'll be happy to stop and we can address them as we go along. So what is spondyloarthritis? It's a family of autoimmune diseases that can affect the spine. So you can see here there's this, we call this the ankylosing spondylitis flower. So in the center we have the characteristic, the poster child of spondylitis, which is ankylosing spondylitis. But other associated diseases are undifferentiated psoriatic arthritis, uveitis, so inflammation in the eye, the uveal tract, juvenile spondylitis, reactive, Crohn's or ulcerative colitis related. And in the audience here, does anyone know why we lump them all together? Yes? Yes. They all are related to the immune system, that's true. But why isn't lupus up there, or rheumatoid? Seronegative. Good. Inflammation and seronegative, yeah? Yes? You were reading my notes. So they can all affect the spine. They don't have to, but all of them can affect the spine, whereas rheumatoid doesn't affect the low back, as an example. And there are stronger associations with this gene called the HLA-B27, which I'll talk about down the road. So how severe is it? There's a wide spectrum. So not everyone with spondylitis is going to end up totally fused, and so there's a variety of clinical outcomes here. Just kind of before we used biologics, there's a cohort looking at patients with a diagnosis of AS, and 25% of them were on full disability, 65% were at risk of disability. And in an Ontario study done by one of my mentors there, they demonstrated an increased risk of vascular death, heart attacks, and strokes in spondylitis patients. Stronger in males than in females, but there is suggestion that there's an increased risk of death if you have spondylitis. So what exactly is being affected? So we've got arthritis, these other words that you might hear, enthesitis, dactylitis, and spondylitis, all different areas of the body that of the musculoskeletal system that can be affected. So arthritis. So here's a picture of a joint. You might see a cartoon version. So it's arthritis is technically inflammation of joints. Joint is the structure that connects two bones, and bones are the bones of joints are capped with some cartilage. So that baby blue there is the cartilage there. Acts as a shock absorber and allows the bone ends to glide smoothly when you're moving. So if you imagine this might be your knee, as you kind of bend and flex your knee, The cartilage helps that glide smoothly. A joint capsule surrounds the joint, and the inner lining, that hot pink or more red, is the synovium. That can get inflamed, and the synovium produces nourishing fluid, kind of that pink area there in the cartoon joint, that kind of nourishes all the structures in there. And this arthritis is a hallmark of this disease here. So this is an example of arthritis. So who can tell which knee is affected here? Well, for those who can't tell, it's the black arrow sign. So it's the right knee that's grossly swollen, or your left there. So, a lot of times patients with, say, osteoarthritis say, my joints are a bit swollen, and to some degree people do have a little bit of puffiness. Sometimes it can be harder to put the rings on in the morning, but when we're kind of talking arthritis, we're meaning big swollen, or you can feel the fluid in there. Sometimes if you're unsure how much fluid, you use tools like ultrasound or MRI to really diagnose the degree of fluid, because there's a normal amount of fluid and there's an abnormal amount of fluid, and we're kind of looking for the abnormal amounts. So enthesitis, so it's where the tendon or ligament inserts into the bones. So you can see here that the muscle there kind of becomes a tendon, and the tendon attaches to the bone at the enthesial insertion, and those are areas that are often affected in patients with spondylitis. So on the right, you'll see the skeleton and those black little dots. It might be hard to see, but if you can squint your eyes and notice, those black dots are areas that were known enthesial insertions. So often we have the plantar fascia, so at the base of the heel, or the Achilles tendon. Other things, the side of the legs. Often people say, my hips are painful. When they're pointing to the sides of the legs, that's more an enthesial insertion. Or tennis elbow, around the elbow, golfer's elbow as well, supraspinatus, so near the top of the shoulder. Those are all areas that can be affected, which are different than arthritis, but enthesitis there. Example. So this is a very obvious example. Once again, we have the black arrow sign. So the right Achilles tendon there is grossly swollen and inflamed. But sometimes it doesn't have to be that swollen and that inflamed to be involved. So dactylitis is what we call sausage digits here. So you can have fingers or toes that become kind of totally swollen, where you can't, normally if you hold your hand up and you look at the joint, you can see it's narrow, and then around the joint it kind of comes out where the bone is, and then it goes narrow again, and then where the distal or the further joint comes out again. In the sausage digit, the whole thing's swollen, and you can't really see where the joints are. It's just one big swollen digit there. And what actually is happening is you get swelling and inflammation in the joint, as well as in the tendon sheath. A little bit in the bone and a little bit in the soft tissues as well. So that's a kind of a different mechanism there. And spondylitis, which is kind of the topic of my presentation here, inflammation of the spine. So oftentimes people get pain in their low back. Buttocks are very common. So when you get buttock pain, that's usually often because of sacroiliac joint pain. A lot of people come to my office saying, I've got hip pain. Well, the hip pain's usually felt in the groin, because that's where your hip joint is. Side of the legs is more greater trochanter, generally speaking. I mean, this, you can't be 100% all the time, and the buttock pain often either is low back or sacroiliac joint pain there. So in spondylitis, you have inflammation here, and it generally in axial spondyloarthritis, it starts in the SI joints and then can go involve the rest of the spine there. And it's estimated to be pretty prevalent in different populations. For example, in Crohn's patients, anywhere between 15 to 40% of patients on X-ray or MRI will show evidence of inflammation in the SI joints there. You can see on the X-ray on the right there, the SI joints are these two, they kind of look like curves there. I don't know if, let's see if I can pull up a pointer here. Here. Can you see this arrow here? No, not so much. There you go. Okay, so these are the SI joints here. This is the right, and this is the left. And I'm not sure if you can see there, but it looks irregular. So the contour should be smooth, kind of like here in the pelvis, It should be a smooth line. Sometimes it's hard to see because bowel gets in the way, or if someone has a little bit more weight, the x-rays have a hard time penetrating. But here if you can see from where you're sitting, it's kind of irregular. It looks like little rat bites coming off the bone there because of the degree of inflammation. And in some patients, you actually get fusion of the bones, where the bones start touching each other, and there's no more joint space there. On the left here is the MRI. So in the last 10, 15 years, we've become more aware that a lot of patients with inflammation in the back never get x-ray changes. And so they may only have MRI changes. If you have MRI changes, they may evolve into x-ray changes given enough time, but they don't necessarily. There's a significant proportion of people with MRI inflammation that never progress to x-ray definition, x-ray damage, but they still have bad pain. They respond to therapy, and they're suffering just as much. So it's something that we need to raise awareness for a lot of the referring physicians, because I think the traditional mindset is Caucasian, male, views like this, x-ray changes. And if you don't fit that category, then a lot of physicians aren't thinking about axial spondyloarthritis. So this is my generic formula for diseases, for autoimmune diseases. I say if you have a genetic predisposition, environmental trigger, and bad luck equals disease. And you can substitute that for lupus or rheumatoid, Crohn's. So in this case, your genetic predisposition is your HLA-B27. But just having that alone doesn't give you a disease. So if you just had a B27 and no other symptoms, then your risk is about 2% of getting axial spondyloarthritis. But if you have Crohn's, or you have back pain, or you have inflammation in the eye, then that risk definitely climbs up. Environmental triggers and bad luck I'll talk about in a second. So the genetics here. So B27, roughly 10%, maybe a little bit lower, about 7% in Caucasian populations, slightly lower in Chinese. Africans have even lower, less than, and Japanese as well. Most patients with spondyloarthritis are positive, so 80 to 90% are positive for the gene, but you could still definitely have disease with negative, like not having the gene and still having disease. So it's not a complete exclusion, but it's useful for screening. Now, if you have a first-degree relative, so mom, brother, sibling, with spondylitis, your risk is about 15%. But if you're B27 negative, then it kind of drops back to general population or less risk. So that's how much of a driver that genetic marker is for your risk. If you have an identical twin, it's about 65%. So it's not 100%, right? There's something in the environment or bad luck that is triggering this. And if you have a second-degree relative, then that risk drops almost back to the general population. So it's really within that the first-degree relatives there. So here's a map of the world, and it's kind of the known prevalences of B27. You'll notice right here with British Columbia. So this 50% is in Haida Natives, Haida First Nations people. They have one of the highest known prevalence of HLA-B27, and their risk of ankylosing spondylitis is if not the highest, one of the highest in the world. The general population, though, amongst most Caucasians, is roughly 7 to 10%. So there's over 100 known genes to be contributing to the risk of developing AS, but the biggest one is B27. Combined, all those genes explain maybe 30% of the heritability is what the genetic experts would say, and over 80% of that heritability is from the B27. So environmental triggers. So smoking. I don't know if any of you are still smoking or thinking about smoking. Should not think about smoking. It definitely increases your risk of developing disease. If you have disease, it increases your risk of the severity of disease, decreases the effectiveness of therapy, also increases the risk that your therapy will fail. So if you are smoking right now, you should think about quitting there. Other environmental triggers, things like infections. So we know that chlamydia and certain diarrheal illnesses, Shigella, Yersinia, Salmonella, Campylobacter, C. difficile, Clostridium, can increase your risk. And so we kind of lump that before as reactive arthritis, where someone might get chlamydia, for example, treated, and then a couple of weeks later they get a swollen knee or back pain. And so we know that certain infections can increase our risk, but the majority of patients with spondylitis don't have a readily identifiable infection that we're aware of, at least. And then they've been hunting. Klebsiella has kind of always been, they've tossed this idea around, but I think they're leaning away from that concept that Klebsiella is driving this disease. Other environmental triggers from the gut. So we've got the gut microbiome, which is a hot topic in all autoimmune diseases, and particularly in spondyloarthritis. But there's a strong link between axial spondyloarthritis and inflammatory bowel disease. So roughly 15% of IBD patients get AS, and 5% of AS patients develop IBD. So one of the large groups in Belgium, every patient with spondylitis in their clinic, they get a colonoscopy, regardless of whether they have symptoms. Now, I'm not exactly sure how they convince all these patients to get the camera there, but they do the colonoscopy, and they'll do random biopsies, and on biopsy, 60% of their patients have subclinical inflammation in the gut. Now, most of the time, it doesn't go into full-blown Crohn's or ulcerative colitis, but just to say that there is some inflammation there. Now, some of that could also be driven by anti-inflammatories, but there are some genetic links between Crohn's and ankylosing spondylitis that make sense of why there's some overlap there. And that same group has shown that inflammation seen in the colon on colonoscopy is associated with more severe disease, with more inflammation on MRI and things like that. So it's a hot area of research, and we're trying to understand more. So how else can this manifest here? I kind of talked a little bit about the peripheral arthritis. So some people, usually it's asymmetric, it's the large joints, so knees, ankles, sometimes elbow. But most people don't get arthritis with axial spondyloarthritis or ankylosing spondylitis. But if your knee blows up, that's very helpful in the diagnosis. Uveitis, so inflammation in the eye. So you could probably see that red, beefy eye. It doesn't have to be that red. If you have painful eye, bright lights are bothering you, especially if it's red, you should definitely see someone who's got the equipment to make a diagnosis. So if you see me, or if you see your family doctor or whatnot, it's not a lot we can really do because we don't have the tools to look inside the eye to see if there's inflammation. So I would suggest see an optometrist or an ophthalmologist because you need to see in the back of the eye with the right tools if there's inflammation. Enthesitis, as I kind of mentioned, Achilles tendonitis and plantar fasciitis are very common. They're also very common in the general population, so it's sometimes hard to tease that apart. Patients sometimes come with symptoms that don't quite meet criteria, but they have a lot of enthesitis, and it's always a diagnostic challenge because enthesitis is so prevalent. Like, people who run a lot are going to get plantar fasciitis, so it's hard to make a diagnosis purely based on enthesitis, but it's a clue at least. And colitis, as I mentioned, so inflammation in the colon, lots of diarrhea, blood and stool, abdominal bloating, all things that if you have a history of ankylosing spondylitis and you've got one of those three, then it may be worthwhile seeing a gastroenterologist for that. Dactylitis, so swelling of the fingers, not common in ankylosing spondylitis, but it's more prevalent in psoriatic arthritis, which we'll hear about later in the evening. And psoriasis as well. There's some overlap. Now, the challenge is if they have psoriasis first and then they get back pain, they often go to Dr. Chandran, and he'll call it psoriatic spondylitis. But if they got the spondylitis first and then they get the psoriasis after, they often come to me, and then I'll say they have ankylosing spondylitis with psoriasis. So it's a bit of semantics there. So how is it diagnosed here? Some water. We used to use the modified New York criteria, so there's some clinical features. Either it has some inflammatory sounding things on the history, maybe some restriction in range of motion, and x-ray changes. That was kind of in 1984, that's when the criteria came out. That's kind of been for many years the standard. And here's more pictures of the SI joints here. So you can see these are pretty severe. It's graded from 0 to 4. 4 is completely fused. 3 is lots of erosions and sclerosis and some change in the joint width. Either there's so much erosions that it looks wider because the margin's already been chewed up, or it's beginning to narrow, it's starting to fuse, so that would be a grade 3. And grade 2 is when you see those changes, but the joint space width is still preserved here. So here's grade 3 and here's grade 4. So, and the spine, you might have all heard. I think if you Google ankylosing spondylitis, you might have seen the picture of the Royal Air Force pilot as they followed him over the decades, and he slowly got hunched and hunched and hunched over. And that is something that I think a lot of patients are concerned about. I don't want to end up like that. And to reassure most people, only a small minority of patients go down that course. And there's some studies suggesting that our therapies may alter that course and prevent that from happening. But even before we had the TNFs or the biologics, only 30% of people have rapid radiographic progression and end up totally fused. There's about 40% of people who have some radiographic progression, so a few of these bone spurs you can see here. And then there's another 40% that had none. They had definite changes in their SI joints. They had the story, they respond to therapy, but they never got fused up. Their symptoms, though, are pretty equivalent. Like there's poor relationship between how many bone spurs you have in your spine and how you're functioning and how much you're suffering and how you respond to therapy, which to me are much more important than pretty x-rays. So here's what a normal spine would look like, and here's this quote-unquote bamboo spine that you might hear about. So enter the MRI era. So as I mentioned, we know that x-ray changes take years to develop often, and so we're trying to capture people early to see if we can intervene early. And in the 90s, the Germans were doing a lot of MRIs, and they were finding a lot of people you see the white part here, that's fluid, that's inflammation in the SI joints. And so these people who were B27 positive often or had a very convincing history, and they did an MRI and they showed a lot of inflammation in the SI joints, they were often progressing to develop ankylosing spondylitis. But as I also mentioned, not everyone progresses, but these people, if you have that much inflammation in the SI joints on MRI, you're probably pretty likely to respond to a TNF inhibitor as well. So, and the pain scores, the function scores are pretty equivalent. There's a huge delay in diagnosis. In general, the average delay is 9 years, and it tends to be worse for females. So when you can see this line, the pink dots are females and the blue dots are males, and this is their symptom onset, and then this is when they were diagnosed. So on average, it was 9 years, and some studies in Montreal, I believe it was an 8 to 10 years average delay in diagnosis, and largely because a lot of patients see their family doctor and or some other walk-in clinic, and back pain is such a common thing in the general population, and so it's mechanical back pain, brush you off. And so raising awareness about the prevalence of spondylitis is very important, and I think it's something that in BC here that we need to be working on. So our current, yes. Mm-hmm. That's a good question. So part of it is that women tend to have less radiographic changes. So they tend to have less X-ray changes, right? So, and the previous understanding was if you have X-rays that are negative, you don't have spondylitis. I think a lot of people going through residency are still taught that. And that's something that I'm trying to dispel when giving educational talks to physicians. That's one component. I don't know, Dr. Chandran, if you have any other thoughts of why it's such a discrepancy.
The X-rays are hard to read, and women tend to have less X-ray change. They have more peripheral symptoms, so that's primarily the cause of delay. So the X-rays are hard to read and less changes in the
Yeah. So our current understanding is there's an umbrella term of axial spondyloarthritis, so inflammation, autoimmune inflammation in the spine. And if you have positive X-rays, we call that ankylosing spondylitis. And if your MRI is positive but your X-ray is negative, we call that, it's a long word, long-term, mouthful, non-radiographic axial spondyloarthropathy. If you have a strong clinical suspicion, so you've got the gene B27, but you also have other features. So as I said, having the gene doesn't give you a disease, but having the gene plus a very convincing history, plus a big swollen knee, plus Crohn's, plus a good response to anti-inflammatories, that, we would say would propel you into that clinical diagnosis of non-radiographic axial spondyloarthropathy. Why is this important? So patients who receive therapy earlier from symptom onset tend to have a higher chance of getting into remission, may be able to go into drug-free remission. That's a bit of a controversial statement. I'm putting myself on a limb there, and may be able to prevent progression of spinal fusions. So it's different than in rheumatoid. So in rheumatoid arthritis, from symptom onset, you've got the clock is ticking before you get on adequate therapy, namely methotrexate or something stronger, because damage is happening within 3-6 months for rheumatoid. Ankylosing spondylitis is a very slowly progressive disease. So the clock is, like, in terms of preventing progression and chance of response, we're talking more 2 to 5 years. Obviously, if we could avoid people from suffering for that long and just catch the diagnosis early, that would be optimal. But in terms of chance of response and possibly preventing progression of these bone spurs, we have a little bit more time to play with. And I think sometimes as well, patients are kind of on the fence about whether or not they'd want to take that next step from naproxen, for example, to a biologics, is a big gun. So we don't have to make that decision today, or within a couple of years. You can make that decision and what's right for the patient. When I say chance about drug-free remission, I'm not sure if I'm mentioning this later in the talk, but they've done studies where it was X-ray negative, so MRI positive, and they gave people treatment for a year and then they stopped it. And at 1 year after, about 40% of people were still in remission. Now it's hard to know how many of them would have been in remission anyway, spontaneously gone into remission without therapy. But when we know in ankylosing spondylitis, once you've started the biologic, when they try to stop it, about 95% of people will end up with the same degree of symptoms. You're not any worse off, but you need the drug to continue being pain-free and functioning. We do know that we can probably get the dose down a little bit with time, and some people are lucky and can come off. So the goals of therapy are typically function, pain, and stiffness. Those are, to me, what drives most things, and things that are important to patients. So if they're working or playing sports that they enjoy doing, or participating in social activities, being intimate with their partner, I think those are all valuable descriptors of how they're doing in life. And I don't just look at a number and say yes or no. It's kind of the whole picture. And I mentioned this probable reduction in spinal fusion. It's hard to study. You need these changes happen over 8 to 10 years, and you need a long-term study with a large number of patients, and it's hard to keep patients in a protocol for that long. And you also are not going to keep anyone on placebo for 10 years. So so it's hard to prove, but we definitely, in the spondylitis clinics, we don't see the same degree of fusion as we saw 20 years ago. And the people who respond, if you wait 10 years from symptom onset, your probability of response to biologics much lower. So what are the options? So this is kind of, we were looking through, when I was in training in Toronto, we're looking through the, what was the distribution? So it's not exactly representative of all clinics, because it is, Toronto was a tertiary referral center. But within this clinic, they had 15% of people who were able to do core strengthening exercise. That's all they needed, and their pain was adequate. They were happy. Roughly another 30 to 40% said, you know what, on anti-inflammatories taken as needed or regularly plus exercise, I'm pretty happy. I can live life the way I want it. If this was not going to change in the next 10 years, I'm not getting any better, but I'm not getting any worse, I'm satisfied. It's about 30% or so. And in our cohort, we had about 50 to 60% of patients who were on a biologic there. And about, I can't remember off the top of my head how many of them were on biologic plus the anti-inflammatories to keep things at bay. And in 2017, we got a new drug coming out, Cosentyx, which is shown to be the numbers look as promising as the TNF inhibitors did, and it also seems to work quite well in people who failed a TNF inhibitor. So how effective are biologics? So if you take patients with spondylitis, roughly 50% of people on the first try will get a 50% benefit. So if your pain was 6 out of 10 or 7 out of 10, it might go down to a 3 or 3.5 out of 10. 30% of people get complete recovery, no symptom, like pain is 0 or 1. And if you don't respond to the first TNF, there's still a good chance you may respond to a second one. For many people, it's life transforming, improve quality of life, return to work, participate in leisure activities. But if you can manage your symptoms on exercise or NSAIDs, I'm very happy too, because we try to be responsible with healthcare dollars, and these medications also have slight infection risk as well. So can I get off my meds? I kind of alluded to this earlier, but if there's X-ray changes, then most of the time it's hard to come completely off medications. Maybe 5% of people can. We are doing studies, or the spondylitis people throughout the world are doing studies about reducing the dose. So rather than once a week, every 2 weeks, every 3 weeks, or longer, or reducing the dose. And if you have a non-radiographic SPA, so no X-ray changes, then and you're treated early, then maybe we can get people off a little earlier. So are these safe? So these are kind of the numbers that I tend to quote in my clinic here. NSAIDs, so anti-inflammatories, that includes naproxen, diclofenac, Arthrotec, Celebrex. So gastric upset's the main one. So 15 to 30% say it upsets their stomach. You can try to take it with food. You can add a stomach protectant as well. Less than 1% of long-term users have a major stomach bleed. And so that's a huge inconvenience. If you have a stomach bleed, there's a 5% chance of dying. So it's not super huge, but you have to go to hospital. They got to put the scope down. They got to put the drip in. It's noisy in the emerge. It's not a fun time, but it's not a common side effect, but something to take into consideration. Heart attacks and strokes. So all of them except maybe naproxen, there's a 30% relative increased risk of heart disease. So it depends on your baseline risk. So if you're young and you take the medications, then your baseline 10-year risk is quite low. So if it was 1%, it goes to 1.3%. But if you're 90, you smoke, you've had 3 heart attacks, then an NSAID might not be the best choice for you there. It's questionable what the risk is with naproxen. It seems to have properties similar to aspirin. It seems to be definitely less than the other anti-inflammatories, but whether it's cardiac neutral, beneficial, or slightly cardiac negative, hard to prove, because you can't give people placebo and see who's going to get a heart attack from your drug. Possible benefit with spondylitis patients. So there have been a couple studies looking at, out of Toronto, they looked at the mortality study, heart attacks and strokes, and those on NSAIDs actually had a reduced mortality, possibly because it's controlling the inflammation. There have been other studies looking at NSAIDs in other inflammatory diseases, rheumatoid and spondylitis, and while in those studies there was still an increased risk in heart disease, it was less than compared to the general population. So maybe there is some anti-inflammatory response that's happening that's protecting the heart. And kidneys. So in general, I do blood pressure regularly. I'll check the kidney function. I do it twice a year. And less than 1% of long-term users have generally reversible kidney issues. So it's not a huge issue, but it's a factor that you need to monitor for. So biologics, infection risk. So I generally say it's roughly doubled risk of minor infections. We do check for things like TB and hepatitis, obviously, before starting. When you read the literature, there is an increased risk, and it depends on the disease, though, right? So in rheumatoid, they're on prednisone, they're on methotrexate, might be on other drugs in addition to the biologic. So yeah, that risk is significantly higher. And the people who get biologics are more severe, and so they're often on these combinations and on high-dose prednisone. Spondylitis, there's no role for prednisone. There's no role for, if it's just the spine, there's no role for methotrexate or sulfasalazine. So you're much less immunosuppressed on the biologic alone. And when they did the study in Toronto with the cohort, there was no increased risk in infections that they found. Drug-induced multiple sclerosis, very rare. Generally reversible. When I was there, we had about 3 patients who had it. 2 of them it reversed when you stopped. They had optic neuritis. 1 patient it didn't reverse. Having said that, they had a brother and a dad with multiple sclerosis. So you wonder maybe it would have happened anyways, hard to say. Drug-induced psoriasis. So interestingly, this drug is very effective for treating psoriasis, but in some people it causes psoriasis. And when you stop the drug, generally it will reverse. But it's, that's a possible adverse reaction. Cancer, we don't think so. The literature is it's hard to prove because you need to follow people long term. You know, it's the duration of exposure, and when you're doing a long-term study, risks of certain cancers are very low, so it's hard to prove. But overall, there doesn't seem to be a major signal in cancer in any of the diseases, really, using the biologics, at least in the rheumatic diseases. I can't speak for Crohn's and other non-rheumatologic diseases. So biologics are powerful but very expensive, and so on average, the drugs cost $20,000 a year. In 2010, biologics comprised 14% of the Canadian pharmaceutical market and cost $3 billion a year. So Canada also lacks a national drug plan to negotiate. So we can't say we, as a country, we're bargaining. We've got how many million people who need this drug. Give us a lower price. It's all provincial formularies, and so our bargaining power is lower. But enter biosimilars. So this year they approved the Remicade biosimilar, and in the year in next year and the year after, they're going to be almost every biologic that's out there. There's at least one, if not a handful, of biosimilars coming out. So they're starting to make their way into the market, and companies are starting to make. They're essentially identical to the original. To be licensed, companies have to do only one study. So, you know, when, say, Remicade came out on the market, they had to do a rat study, a human study, dose study, efficacy study, a phase 3 study. They have to do long-term studies, multiple phase 3 studies. So these, you know, it costs a lot of money to bring a drug to market. For the biosimilars, they just have to do the one phase 3 study to show identical efficacy. So they can't show superiority, they can't show inferiority. They have to show that it's identical. And in BC here, it's thought that the medications will be priced somewhere between 30 to 40% cheaper than the original drug. They're not allowed to disclose the actual cost. That's kind of behind the doors negotiations. But, you know, sometimes you wonder, because these are complex molecules here. So you can see this is aspirin. That's how complex aspirin is. And this is human growth hormone. And this is the biologics, you know, much more complex, like 1,000 times more complex than aspirin. So you want to know that the company that's making the biosimilar is good. And you know, Samsung, many of you have Samsung phones, or it's one of the leaders in terms of producing these biosimilars. I don't know if you guys know, they also make tanks and they make computers, and they have this huge industry in Korea. But other companies, like, for example, the makers of Enbrel, are making a Humira biosimilar as well. So efficacy and safety. So many studies show when in these trials, when they show identical efficacy, they also show very similar safety. Safety profile seems to be reassuring, although we would like long-term data, of course. There's some concern about whether or not it's safe to switch, because as you know, if you're on these medications, some of you might know, your immune system may begin to recognize that this is a foreign protein and produce antibodies against the drug and cause it to fail. And so in Crohn's, where there's a lot of failures, they know that if you keep switching drugs, your body keeps producing more anti-drug antibodies, and your risk of failure of the next drug is even higher. So, you know, the question is, if you switch in, say, a spondylitis patient from Remicade to Hospira or Remsima, is that the same thing? We don't know. But they're doing major studies in Norway to address this issue. So the data will be out, hopefully by the end of the year, or maybe next year, to reassure. So I think to start someone on it, I don't think there's any question about efficacy and safety. We think it's pretty identical. They do a good job replicating the molecule. But the question is switching. I don't think we know. So some of the newer agents out there. On the pipeline, so Cosentyx, IL-17A inhibitor, had great results, great for psoriatic arthritis, also for ankylosing spondylitis. And it just got approved, but I think they're going through the negotiations of pricing right now in Canada. And as I mentioned, the studies look pretty comparable to the TNF inhibitors and seem to also be very effective in people who've failed a TNF inhibitor. And Stelara, used to treat psoriasis. A small study showed some benefit. Now they're doing a big study to prove it. So a little bit of rehash here. So Cosentyx, extremely effective for psoriasis, as we'll later hear about, and psoriatic arthritis. good response in TNF non-inhibitors, and some promising data on stopping or slowing spinal fusion, but the jury's still out. Stelara as well, very effective for psoriasis. Used to treat Crohn's and ulcerative colitis. So you've got that combination. That's a good one, a good consideration. And a small study seemed to suggest it works, and they're trying to prove it out. So in summary, hopefully I've highlighted for you guys what is axial spondyloarthritis, what's being affected, kind of general concepts of how does this happen, how does it manifest, how is it diagnosed, and what are the potential treatment options. Any questions?
Please.
Oh, yes.
Does that mean, I didn't understand this BN27 thing, whatever it was. Do I have BN27? Should I have BN27? I'm lucky I don't have it. I just don't understand.
So it's a gene that you're born with or you're not born with.
How do I know?
You could check it, but if I don't know your medical background, you don't have to divulge. But if you have ankylosing spondylitis,
60 years.
then you don't really need to check it. I would say, unless you're part of a research study, because it's not going to change your management. The other caveat is sometimes they don't like to check it because if you have children, insurance companies, if they get a hold of that, that could affect premiums. Pardon, sorry? It did, yeah. So that's a risk because there's no guarantee that your kids will get it, right? So, yeah. but if you're being worked up, if you have back pain and they're trying to figure out, do you have this? Then we often use that in part of the diagnosis. But yeah. But if you have established disease, it doesn't really matter. Yeah. Yes. So the ones that are approved here are Hospira and Remsima. So they're biosimilars to Remicade. Yes. Administered the same way, yes. But they're all every one of the biologics have a lineup of companies trying to replicate the drug. So in the next few years, we're going to be seeing those. Yes, yeah. Yes. Mm-hmm. Good question. You mean trochanteric bursitis? Pretty similarly, in fact. And the management's pretty much the same too. You want to do glute med strengthening, hip abduction. We used to inject them. I don't know if you guys still inject them. I tend not to just because I think there's some suggestion that you might have greater recurrence. Like you get temporary benefit and then possible more recurrence of the bursitis down the road. Yeah. Of cortisone, yeah. Up until 2 months ago, I was injecting them, and then we had this discussion, and it was brought to my attention that maybe we shouldn't be, so I stopped. Yeah. Yes? I think that's something that's being hashed out by the politicians because, it's out of our control, right? I think if there is any evidence that switching will be negative, then obviously we wouldn't want to write the script and then, for example, then the pharmacist picks which one of the 6 options he feels like. That we wouldn't want that. But that's still not 100% hashed out by politics. I believe your hand was up. Mm-hmm. Yes. Yeah, so there's, as I mentioned, I alluded to earlier, it's hard to prove. We think so. At least I think so. I might be biased. One of our colleagues in Toronto published the paper that showed a huge difference, 75% reduction in progression. The problem is, obviously you can't, these changes are very slow and were only demonstrated after being on the drug for 6 years. So you can't keep someone on placebo for 6 years to compare. So you have to use an older cohort, and people might not be on biologics for various reasons. Maybe they have a bad infection, or maybe they've got bad Crohn's, and that's why. So it's hard to make a perfect comparison, but we definitely don't see as much fusion as we used to see. So, yes. No, you can just go on. They treat latent TB, so INH for 9 months or rifampin, and then after 1 month of that, then you can get started on TNF. Well, it's hard to prove complete eradication, but generally, yes, yeah, that's what we would do. Yes.
You mentioned drug-induced MS. Is there any other connection with MS?
With AS,
MS, yeah, AS and MS.
not that I'm aware of. He's a genetics expert. He's shaking his head, so I don't think so. Yeah. All right.
There is an opportunity as well a little later. There's the blue cards and the things. So if you have thought of a question for Dr. Chan, Dr. Chan and everyone will be available to answer some additional questions at the end if you have some. Thank you, Dr. Chan. Just want to mention that in your packages, there's a yellow form here. This is an opportunity for some feedback if you would do that. We very much appreciate your feedback on these forums. We make a considerable number of changes in the way these forums are run by the feedback we get. The categories are somewhat generic, but you'll notice the top quarter of the page is more likely to be filled out later in the evening because it does relate to the entire conference. But each one of the speakers is listed there, and you can anonymously mark down in general categories. 1 is the poorest and 5 is the best. And we'd appreciate at the end of the conference or at the end of the forum, we'll pick them up at the front counter. So when you're leaving. So thank you very much if you could fill those. Having Dr. Chan speak about ankylosing spondylitis, we thought that at all of these forums, we asked somebody who suffers with ankylosing spondylitis, a patient, to come and to speak for a few minutes on their symptoms and how it has affected their life. And tonight we're very pleased that we have Mr. Jia Hu has come in and is going to speak to us about his ankylosing spondylitis. So please welcome Mr. Hu.
Hi, everyone. Thank you very much for spending your very beautiful Saturday afternoon and evening indoors. It's lovely outside today, though maybe it's always like this in Vancouver. I hear it isn't. And I thank you for letting me speak at the forum today. So by way of brief introductions, I'm a family physician and a 4th-year resident in public health based at the University of Toronto, so I just flew in. I'm originally from China, but mostly grew up in Edmonton. I did used to live in Vancouver for about a year in the 90s, and I do really enjoy my visits here. It's really, really pretty. Anyways, so the organizers have asked me to speak a little bit about my experiences with AS, and I'm happy to share some of my story, sort of life before sort of formal diagnosis, life with the diagnosis, life on various types of medications. But I just wanted to caveat that by saying, you know, I suspect, I'm sure actually, that many of you have had experiences and stories that are, you know, far more difficult, far more challenging, and far more compelling than my own. So I recognize that, and I recognize that I have been extremely fortunate, I think, to sort of have grown up in an era where biologics are available. They haven't been around for that long. To have had contact with a lot of doctors, some of whom are even rheumatologists, which has been very helpful, and also to have the social supports and the sort of wherewithal to deal with the disease. I know there's some sort of family members here, and I think having that support is sort of extremely, extremely helpful in dealing with AS or any chronic condition. So I'll get started now. So I remember the first time I had a manifestation of ankylosing spondylitis. I was 19 at the time. I had literally just moved to Boston, sort of like a few days ago to start school at Harvard. I was studying economics. It was a Sunday night, like 2 a.m. in the morning. I was super excited because it was my first day of class the next day, you know, it was like an undergrad thing. But sometime in the middle of the night, I remember sort of waking up with this excruciating pain in my right foot. I crawled out of bed. I was just crawling around, and it was a bit of a nightmare. I thought, I was in a new place. I didn't know really anybody yet. I had just moved in, and I didn't pack any Tylenol or Advil, so my drug cabinet was bare. The first day of school was tomorrow, and I was thinking, I'm gonna get a good night's sleep, be fresh, and instead I was sort of writhing around in pain. I also had no idea what was going on, and that was a bit scary, I think. So what I ended up doing was I called my mom. She's like, try to go to bed. I called some friends. Might have even called John, actually. I don't know. Anyways, not much you can do over a phone from 3,000 kilometers or miles away. And so after a few hours of sort of just writhing around, I managed to go back to sleep, and it was a bit scary. So unlike, again, many of you, I suspect my AS has predominantly manifested itself sort of peripherally. So what happened that night was, I think, that the first of many flares of a peripheral enthesitis, and I was going to define that, but John already defined it. I learned a lot, actually. It was really helpful. But I wouldn't be diagnosed with AS for many years to come, and I didn't realize the average delay to diagnosis was 9 years. Again, it didn't take that long for me, but it was quite a long time. So the day after my sort of flare happened, I felt better. I was able to sort of hobble around. So I hobbled around to my classes, and later in the week I went to the University Health Center. They have free coverage for students at any rate in the States. I was given a diagnosis of plantar fasciitis, and it sort of made sense at the time. I just ran a half marathon. I do enjoy running a lot, and I probably don't do very well when it comes to stretching or doing cool downs or whatever. So I talked to the doctor. He's like, just, get some orthotics, buy some Advil, and just, stretch, essentially. And that's what I did. So over the course of my university years, I would occasionally be struck by these bouts of foot pain, foot swelling, right foot, left foot, both feet. And they were usually fairly intense, such that I ended up getting a cane and later a pair of crutches to get around when I needed to get around when this happened, because it would last for sort of days at a time. I took lots of Advil, probably too much Advil. I remember there was this 1 4-day period where I took 100, 200 milligram pills of Advil. That's more than you should take, I think. Anyways, I'm fairly lucky, I think. I've never had any sort of GI symptoms or stomach bleeding. Had to go to the busy emerge. My roommates were also really supportive at this time. Whenever I couldn't get around for a few days at a time, they'd go to the dining halls and bring me some food so I'd have something to eat. Sometimes when it happened over a weekend, they would, instead of going out, they'd come home and just watch TV with me, which is really nice. And during this period, I think things were generally manageable. I did have to miss a few classes here and there, but I don't think my schooling was really ever compromised. I couldn't run as much, but I did a little bit in between these flares. Maybe that wasn't recommended, but I felt I had to get out there. I think the only big event out of my sort of undergrad experience that I missed was we had a sort of a graduation ball, and both my feet were really inflamed and swollen at the time, and so I decided just to not go and just stay at home because it seemed kind of awkward to hobble around. Anyways, the bottom line was I didn't think too much of the disease at that point in my life. I had a diagnosis. I was able to generally manage with Advil and orthotics, and if I had to miss a bit of school, so be it, because who doesn't want to stay home sometimes. Right after school, I ended up going to China to work for the World Health Organization for about half a year. And during that time, my parents were a bit worried because they're like, oh my God, you're going away, what's going to happen? But nothing really bad happened. I had no flares at all, which is probably the longest period I had no disease flares since I had first started having them, which is lovely. And it's something I was really passionate about, global health, international health. It's something I still want to do. And so after that, I ended up moving home to Edmonton for med school. And I guess there weren't any really big changes to the whole AS until about 5 years after that first diagnosis, 2009. And I remember one summer I was playing a game of tennis, and I don't normally play tennis. And after I played, I noticed my right elbow was very swollen. I'm like, okay, maybe I just didn't stretch, whatever. And it kept on getting more and more swollen. So getting more swollen by every day, and I attributed it to overuse initially, but it wasn't really ever getting any better, and so it eventually got to the point where I couldn't really bend it past like this point. So it becomes harder to write, harder to type, it became sort of hard to eat as well, so I had to learn how to use my left hand. And about the same time, actually, I noticed my opposite knee, my left knee, was getting very swollen as well. So again, limited range of motion, makes it hard to climb up and down stairs. And so I was getting a bit worried again. This seemed quite different than sort of plantar fasciitis, because that doesn't normally lead to joint swelling. And at this point, I had just finished my first year of medical school, so I had some idea that multiple joint swelling up for weeks at a time wasn't normal. I think like after you finish your first year of med school, you think you know a lot, but you actually know nothing, effectively. So I was thinking, oh, maybe I have rheumatoid arthritis. I don't know, because that's what we learned about. Throughout the process, I did have some lower back pain as well, but it was the joints really sort of affected my function and made it sort of hard to get around. And so maybe I'll pause and take a brief aside and ask, what is health? So, I mean, having lots of back pain, lots of joint swelling probably means that you aren't healthy, though maybe if your symptoms are controlled, maybe you are. Maybe is health the absence of pain, of the absence of swollen joints? Is health being in a good mental state where your mood isn't down? I think all these definitions of health are quite negative insofar as health is portrayed as the absence of sort of bad things happening to you. A definition that I quite like of health that the WHO has is it describes health as a resource for everyday life and not the object of living. And I think for most people, health is valuable insofar as it's got some instrumental value. It lets you do the things that you want to do in life. Whether that's a stroll along the seawall on a beautiful day like today, whether that's chasing after your kids in a park, or chasing after your dog, or just being able to get into a car and drive to the movie theater and watch like a new superhero movie. That's kind of why I suspect rheumatologists, they obviously do this, but I think it's important to sort of ask patients like how whatever it is they're afflicted with is affecting their function and how it's impacting their day-to-day life, because that's why we stay healthy, so we can live life, enjoy life, do things we like to do. So at this point, sort of with like multiple joints swelling and flares of plantar fasciitis erupting here and there, I began to feel as if my life was becoming increasingly affected. I was missing tons of school at this point, as getting to school was becoming very difficult. I skipped anatomy a lot because you had to stand for 3 hours, and I'm like, oh, it's very painful to stand for 3 hours, so I just wouldn't go to that. That's why I'm not in surgery. I suspected, I had some sort of inflammatory arthritis, and I began to wonder what that meant for what I wanted to do with my life. Just a few months before my tennis game, I had spent 2 months working in Zambia, which is a sub-Saharan African country, working in a hospital that had a lot of HIV patients. They have a lot of HIV there, lots of very ill people. And I was planning on going back the following summer. And I was just thinking, is this possible? Is this feasible? I just longer term, I began to wonder if the things that I sort of dreamed of doing for quite a long time would still be within reach. And having that sort of strike me was probably the most worrisome thing about the disease. Fortunately, I did mention that I was very lucky to know people, so it just so happened that a friend of mine happened to have a father who happened to be a rheumatologist, and I was able to call him, actually, and I know most people don't have that access, and I'll speak to access actually a bit later, but I was lucky enough to have that access, and he basically got me into his clinic quite quickly. He drained the fluid from my elbow, which had like 100,000 WBCs in it. It was very inflammatory. Sent me for HLA-B27, which I had, and I think it's less common in Asian people, from what John tells me. Had an MRI, which also often takes a long time for a lot of people. And everything sort of came back positive, HLA-B27 positive. I had some sacroiliitis, elevated ESR, elevated CRP. And so he diagnosed me with a seronegative spondyloarthropathy. I get all these terms confused still. And I'm technically a doctor, so I don't know if family doctors need more CME, I think. Anyways, he started me on sulfasalazine. so the sulfasalazine was pretty benign, actually. Basically didn't do anything. It wasn't bad. I just had to take my pills every day. But because it didn't do anything, he soon put me on methotrexate. And this medicine actually also didn't do anything in terms of controlling my disease. But what it did do was it gave me really bad mouth ulcers. So having like 7 canker sores in your mouth. And so really it just made it really hard for me to eat or drink or to talk. It was very painful and very annoying. And so this is probably like the darkest time, right? Because you're like, I'm on these 2 drugs that are supposed to be working. Instead, I can't eat. My joints are swollen. I'm missing school. I definitely can't do any physical activity. So I just like lie on my couch all day. I was thinking, a lot about, again, the long-term consequences of uncontrolled disease. I really began to doubt that I could sort of do what I wanted to do. Like, sort of, you have this identity about yourself and what you envision you're doing, and I felt that fraying a lot at this period of time. So it was quite dark for me, I think. But again, I think fortunate because biologics had been invented about a few decades ago. And after about a year of being on this treatment, he put me on something called Symphony, which is gomalimumab or something. Anyways, I can't prescribe it. And my understanding of biologics is that they have been quite revolutionary in the treatment of spondyloarthropathies and autoimmune conditions in general. And so the opportunity to access this sort of treatment was a huge, huge blessing. Essentially, I didn't realize that only 30 to 50% of people sort of had a response. I don't know if I heard you correctly, but for me, at any rate, within 3 months, I stopped having any flare-ups at all. It worked like magic, actually. I did try to sort of go off it at some point, like my rheumatologist would be like, can you extend it? And I tried, but that didn't work. So I'm sort of chained to it, but better chained to it than swollen joints and mouth ulcers. I was able to spend the next summer working back in Zambia, which I wanted to do. A few months after that, I was able to start running again and training for a marathon. And effectively, I have been disease-free since then. So really taking this once-a-month injection, which is pretty easy to do, has really given my future life that I plan to have back to me, and I really appreciate that. I even actually get the sense that John, who's my best friend actually, might have specialized in rheumatology and ankylosing spondylitis because of my experience. So, but thank you. It was very nice to see you up there, clinical assistant professor. It's very cute. Just like. So, as a public health physician, I'm not an expert in rheumatologic conditions or inflammatory arthropathies or ILs or HLAs or any of those things. Those are best left to these two. But what I do know probably a bit more about is sort of healthcare policy and pharmaceutical policy, and that's something I've sort of done extra training in. And the other thing that I've learned a bit about is sort of how to advocate for a cause, actually. And I'm really glad that Cheryl is going to be speaking. I haven't met Cheryl, but I went to your website and looked at it, and it was wherever you are, somewhere in the audience, later in the evening, because I think from a patient perspective, these issues of access, being able to see your doctor in a timely fashion, being able to access drugs without really high copays is really important. And I think as patients, we're never going to know as much about the disease as the rheumatologists that we have are. Although I do bet many of you know a lot about your disease after living with it for so many decades. But I do think as patients, we do have a really, really, really powerful voice to advocate for change so that us and others will receive better care in the future. And this means making sure people don't have to wait 9 months to see a rheumatologist. It means that biologics and biosimilars are available for people without having to go for long trials of failed traditional therapies. It means that these drugs, which are extremely, extremely expensive, as John was mentioning, are covered by provincial plans, or better yet, a national plan, though I don't know if that's going to happen anytime soon, with as little in the way of co-payment as possible. I do a lot of research as well, actually, and I, in my opinion, I think from a policy perspective, from a politician's perspective, a few patient stories will go further than a fistful of publications a lot of the times. You need the evidence, but without this, politicians listen to stories more than to listen to New England Journal a lot of the times, actually. So it is what it is. So I just wanted to say that because I think you're all sort of, because you've had this lived experience, you all have a lot of power and wherewithal to make changes to the system, so it's better for people who come up next and who are diagnosed in the future. So I'll close with that for now. So thank you very much for listening to me ramble for a little bit. I'm happy to take any questions or comments, but otherwise I'll step down. Yeah. Yes. Hi.
Well, very, very nice of you to share your experience with us. Just wonder, when you first have the symptom
Mm-hmm.
by to or you were first diagnosed, how long was the gap?
I think it was 5 years.
5 years.
5 years, yeah.
Okay, and then you start your biologics.
Just a year after being diagnosed.
Oh, okay.
Yeah.
And how long have you been on biologics? And are you still on biologics?
Yeah, still on biologics. I think I've been on biologics for like 6 years, 7 years now. Yeah, so I've been on it for a while. I cost the government a lot of money. But yeah.
Excuse me.
Yeah.
Most people here take the drugs. I never took any. I just lived with it. Would it have been better if I'd had drugs to do this?
Maybe was your question, do people actually take drugs?
Do most people here actually use drugs for this?
Who takes drugs? Raise your hands. And who doesn't take drugs and is a patient? Okay.
I'm not a patient. I just.
Right.
Well, yeah, of course I'm a patient.
Yeah.
I'm not a patient. I don't know what I am.
Okay, it's okay. It's okay. Thanks for asking, though.
And the frequency of your biologics is still the same, or?
It's still the same. Like I've tried to. It's once a month. I've tried to bridge it to 6 weeks, but every time I bridge it to 6 weeks, I get like joint swelling again, so I have to stop. But I go back to once a month.
Thank you.
Great. Thank you.
Every time I hear a history of somebody, they're all just a little bit different. I was listening to Gia do his talk about how his disease progressed, and I was thinking about my own, and I'm thinking, you know what? They're all just a little bit different in the way that but the outcomes and the advocacy is the same, no matter who is talking to you from a patient perspective. We all have the same goals when it comes to that. We've talked about ankylosing spondylitis and heard from an ankylosing spondylitis patient. And we're going to move on to another major category of spondyloarthritis, which is psoriatic arthritis. And it's my pleasure to introduce Dr. Vinod Chandran, who has come out from the University Health Center out of Toronto and is going to speak to us about PSA. Dr. Chandran.
Thank you. Thank you for all once again to coming over here. It's 4:45 p.m. Good evening outside, and for me it's like 7:45 p.m. But that's fine. And it's a hard act to follow, Jonathan and Gia. And I'm essentially going to speak about the same thing John talked about. Back involvement, peripheral involvement, enthesitis, arthritis. Psoriatic arthritis is very similar. It's in the context of psoriasis. If you have psoriasis or if you have a family member with psoriasis, then you have psoriatic arthritis when you have these manifestations. So it's kind of semantics. The principles are essentially remain the same. I just heard somebody talk about having a long-standing history of ankylosing spondylitis and then recently was diagnosed as psoriatic arthritis. I thought that's what I heard. Yes. So it's the same spectrum of disease. It's it depends on who you saw and what that physician called you. I would still say you have the same spondyloarthritis and maybe you just developed psoriasis recently, and so it's the same thing that we're talking about. The disease has not changed. So my disclosures, I've received honoraria from companies, research grants mainly from AbbVie, but also other funding agencies, royalties and salary support. So I was asked to talk about what psoriatic arthritis is, what causes psoriatic arthritis, and the medical treatment of psoriatic arthritis. So let's begin with what psoriatic arthritis is.
there's a lot of confusion about arthritis and spondyloarthritis, and so I thought I'll just put in a flow chart of what arthritis and inflammatory arthritis and spondyloarthritis is. So, arthritis is a broad term meaning joint pain, and it's one of the most common condition that affects Canadians, affects the quality of life, affects their function, and the burden is very high. Almost everybody, as they get older, gets some forms of quote-unquote arthritis. But most common form of arthritis is non-inflammatory. So that's what we also call osteoarthritis. And osteoarthritis could be secondary to an injury. Can you see? Oh, you don't see that. Yeah. So the most common form of arthritis is non-inflammatory osteoarthritis, which could be related to an injury. You had a knee injury when you were young, or meniscal injury, and subsequently developed pain and discomfort in that knee, and that is a form of osteoarthritis. Or you never really had any injury and gradually developed problems in a hip, hands, or fingers with knobbly, bony thickening of your end joints, nodes there. So that form of arthritis is also called osteoarthritis. But what we are primarily interested as a rheumatologist is inflammatory arthritis. So there is inflammation within your joint, which is much more than what is present. There's a little amount of inflammation that is present in osteoarthritis. So, and there are two major forms. One is crystal arthritis and autoimmune arthritis. Crystal arthritis, the most common one, is gout. You have uric acid deposition in your joints. Once again, osteoarthritis, gouty arthritis, they are the most common forms of arthritis in the general population. The rarer forms of arthritis are the autoimmune arthritis. And that's where the problem is. So in medical school, it's not given that much of importance. You talk about osteoarthritis, gout, but maybe not that much about autoimmune arthritis. And within the autoimmune arthritis, you can broadly classify it into rheumatoid arthritis and those related diseases, and spondyloarthritis. Now, between these two, again, for historical reasons, rheumatoid arthritis is something that is taught a lot, even to rheumatologists. They don't, talk a lot about spondyloarthritis. When you do studies in the population, the prevalence of rheumatoid is about 1% in the general population. For spondyloarthritis, all the AS, PSA, that's also 1%. But because for some reason, it's not been taught that much in medical school, people do not know much about ankylosing spondylitis and psoriatic arthritis. And I think that's one other reason for a delay in diagnosis. So people know about arthritis, people know about rheumatoid arthritis, they know about gout. I'm talking about healthcare clinicians, but not much about spondyloarthritis. And one of the reasons for having these symposia is to increase awareness. In the morning we had a symposia where we had physicians and nurses, and we talked about diagnosis and treatment. And here also getting it to family members and patients with the condition to understand the barriers. So that's the broad concepts of arthritis and spondyloarthritis. And among the spondyloarthritis, we have the predominant axial spondyloarthritis, so mainly back involvement, or you can have the predominantly peripheral involvement, where you have pain and swelling of the hands and feet. And ankylosing spondylitis is a subset of the axial spondylitis when you have changes on X-rays, whereas the rest is when they have more hands and feet involvement. You have diseases like psoriatic arthritis, reactive arthritis, and arthritis associated with inflammatory bowel disease like Crohn's disease or ulcerative colitis. And that comes into this spectrum here. As you can see, there's a lot of overlap. Now, we heard the story about ankylosing spondylitis by Jian, but the manifestations began with peripheral arthritis. Right? You had enthesitis and knee and ankle and elbow involvement, and the back involvement, from what I could gather, was not that prominent. So you had a predominant peripheral arthritis, spondyloarthritis, but then when the X-rays showed sacroiliitis, the diagnosis was, it was called ankylosing spondylitis. But I think it's a whole spectrum of disease, which it depends on which physician you go to, which manifestation is most predominant, that gives you that name. And typically ankylosing spondylitis begins as back pain. But if you're younger, in teenage years or younger, the kids present with more feet and knee and hip involvement, and the back symptoms are not that prominent. But if you go a slightly older population, like in the late 20s and early 30s, you predominantly have back pain as a major symptom, and the peripheral manifestations are not that prominent. And so it's the age at when the disease develops. Are you male or female? All that, affects the spectrum of the presentation and may confuse the clinician who's seeing you. And that's why looking at the entire picture is important. So psoriatic arthritis, like I mentioned, is a spondyloarthritis. All those features that I talked about associated with psoriasis. So you either have psoriasis. Typically, you have the skin psoriasis first. But some people get the psoriasis later. And then you have inflammation in your joints. It can be in the hands and feet or spine or the enthesis that John described. And it's got a wide spectrum of manifestations. And we used to see a lot, severe arthritis with destructive changes, severe spinal involvement, or involvement. And this is quite common where you have involvement only of the end joints of your fingers. You can have enthesitis and dactylitis. All these manifestations, like John so beautifully described, can happen with psoriatic arthritis. And these are, when you talk about psoriatic arthritis, in addition to all this, you also have psoriasis. So what are the causes of psoriatic arthritis? Now, in many diseases, most diseases, so when you talk about psoriatic arthritis and causes, because it happens in patients with psoriasis, we like to understand why some people with psoriasis get the arthritis and many do not. So if you look at the population prevalence of psoriasis in Canada, it's more than 3%. 3.3% was the latest estimate from the MAP survey. So that's a common disease, but not everybody gets psoriatic arthritis. If you look at lifetime prevalence, it's about, not lifetime, but if you do a cross-sectional survey of patients with psoriasis attending dermatology clinics, about 30%. So 3 in 10, 1/3 of people with psoriasis get the arthritis. So, and 70% don't get it. So what are these, why do some get it and why do not others don't get it? So 70% get it prior to the onset of psoriasis. 15% get it along with the psoriasis. The joint pain and the skin disease happens at the same time. And about 15% get it after the joint disease. So you have, back pain or swollen knees or hand swelling, and the skin disease happens later. But because in 85 to 90% of patients, the psoriasis happens either together or prior to the onset of arthritis, we can consider psoriasis as a pre-arthritic condition. And if we carefully evaluate patients with psoriasis, we can identify psoriatic arthritis early. And there is data to show now that if you identify the disease early, you can treat it better, and the response to treatment is much better. So that's where most of our research and has been in looking after patients who have come to us with psoriatic arthritis, but also looking at our patients with psoriasis who do not have arthritis, and then following them up long term to understand why they are getting the arthritis. Are there genetic factors that are important, or are there other factors? And I'll talk about that briefly. So when you talk about diseases and what causes the disease, and I completely agree with John, there is genetic factors, environmental factors, and stochastic factors, or plainly bad luck. So some diseases have a strong genetic component, and some have a combination of genetic and environmental factors, and some have a strong environmental factor. And so the common diseases that have a very strong genetic influence are diseases like cystic fibrosis. You have a genetic defect, and you almost always get that disease. And the way the disease presents may be slightly different depending on what environmental influence caused the disease. And one example is cystic fibrosis. There are diseases like AIDS that is most talked about. HIV in the previous talk. It's caused by an environmental influence, but there is a virus that causes it. But not everybody who's exposed to that virus gets the disease. And there are some people who progress rapidly into full-blown AIDS. Some people have HIV and never progress at all, without therapy. So, and there are genetic factors that can influence it. And interestingly, actually B27, I know most people in this room who have B27 is cursing that gene. Is saying, why did I get that gene? It caused me this disease. But if you have HIV, thankfully most people don't. If you have B27, you are less likely to progress. So it's a good gene, and maybe that is the reason why the gene is still present in the population. So the genes that cause spondyloarthritis are actually protecting you against progression of this bad viral disease. And so that's the evolutionary reason why that we have this gene. It's a good gene. It gives you a more robust inflammatory response, protects you, but the downside is that it goes too far and you get autoimmunity, right? So that's a problem. And psoriatic arthritis and psoriasis are in between. It has got a strong genetic component, and all the spondyloarthritis has a strong genetic component. B27 is an important gene, HLA-C6 is an important gene, there are other genes, and then there is an environmental trigger, and we'll talk about both of that. So how do you look at genes? We look at families. We compare family members of patients with the condition to family members of patients or subjects without the condition. So if you compare relatives, if you have a family member with psoriasis, your own likelihood of getting psoriasis is about 4 to 10 times the general population. So the general population prevalence is about 2 to 3 times. Your likelihood of getting psoriasis, just a skin condition, is about 20 to 30%. So if you have a family member, your chance of getting the disease goes up 4 to 10 times. And you have psoriatic arthritis in your family, so if your sibling or your father has psoriatic arthritis, your chance of getting psoriatic arthritis is 30 times the general population. Now, so that's what we call a relative risk. That sounds very huge, but since the prevalence of psoriatic arthritis in the general population is only about 0.25%, you multiply 30 to 0.25, it's your chance of actually having it is only about 7-8%, right? But the relative risk is 30 times. That's huge, and that indicates that there's a strong genetic component. What we have then done is to look for genes for this condition, and B27, C6, the HLA region, the region that drives a lot of immune response, is an important gene for the disease. And we compare patients with psoriasis who do not have psoriatic arthritis, and compared to those with psoriatic arthritis alone, we see that the HLA region gives the strongest signal. So, but it's not strong enough to be a diagnostic test. It's not recommended to do it to see if you're at a high risk of getting it. But in research, we see that there is a difference among people who get the arthritis and who do not get the arthritis, among psoriasis patients who get and do not. So genetic factors are important, and we are looking for other genes. The idea for looking for genes is to maybe get a test that you can test for. Many private companies are offering that. I wouldn't go that far. But by doing genetic studies, what we are understanding is about the reasons why, what are the pathways that are affected, and how can you develop new treatments based on that. So many of the genes that are overexpressed in patients with psoriasis and psoriatic arthritis are those same pathways where the drugs that inhibit that, like the drugs that you described, the TNF and IL-17 blockers, they affect the same pathways. And so by looking at the genetic screen, you can say that now you understand why these drugs are very effective. So that's an important advance. We are not trying to predict who's going to get the disease by looking at genes. We're not there yet. And I don't think the genetic testing is going to be that useful because the genetic component is not overwhelming. But so what we can do, the genes you can't change, at least for now, maybe in the future. But environmental factors are things that we could possibly change. So what are the environmental factors that cause arthritis in patients with psoriasis? One important risk factor is obesity. If you're obese, you're more likely to get psoriasis. And if you have psoriasis and you're obese, you're more likely to get psoriatic arthritis. Injury is important. Minor trauma. Our studies show that patients who got psoriatic arthritis, the job involved lifting heavy loads. Major trauma, large population-based studies, and also anecdotal reports show that if you have had a bone fracture or you injure a joint, you're more likely to get psoriatic arthritis. Now, not necessarily in that joint, but other joints also. And so, you wonder with the story that you just heard, how much the marathon running your tennis kind of triggered the disease. You had the B27, you're waiting for that environmental trigger. The micro trauma that happens with any sport injuries, marathon running, your immune system, there's always some amount of inflammation after you. If you run a marathon, you can feel the pain and the stiffness the next day. There is some immune reaction, there is micro injury and there is an immune reaction. But because your immune system is so strong, maybe to prevent diseases like HIV, you overreact to that micro trauma, and there is inflammation within the enthesis, which is where a lot of the biomechanical stress goes through, and from that secondarily it spreads on to the synovium and causes arthritis. So injury is a major risk factor for disease, and you always have to balance between good exercise, protecting your joints, and going overboard and trying to cause more damage by trauma to these areas. Smoking increases the risk of psoriasis, and it's controversial, but we think that people patients who smoke tend to have psoriatic arthritis. Smokers also have a very poor prognosis with regard if they have ankylosing spondylitis, and they respond less to therapy. Infections are also triggers, especially infections that require antibiotic therapy. Then you wonder, is it because of the infection or because of the antibiotic therapy? Because when you take antibiotics, it's like throwing a bomb into your intestines and changing your microbiome. And is that what is triggering the disease? Good question. Lower level of education has also been shown to be a risk factor. Now that's a difficult risk factor, but it could be a surrogate for blue collar work, which requires a lot more heavy manual labor. Smoking, lower education status is correlated with smoking, and other more infections, etc. So all these risk factors have been found in studies that we have done both in the population level and at the clinic level. Now the treatment, I'll briefly go through it. We discussed that. So we look at psoriatic arthritis, which again, I must emphasize, is associated with skin disease, as well as pain and swelling and inflammation in your hands and feet, joints of the hands and feet, but also sometimes the back pain. You treat them with anti-inflammatories, sometimes with corticosteroids, drugs like methotrexate, leflunomide, and sulfasalazine, called conventional synthetic DMARDs, the biologic DMARDs, and the targeted synthetic DMARDs, the apremilast. So NSAIDs are given to almost everybody with more than minor pain. It's used for symptomatic management, immediate pain relief, and maybe sole therapy for mild disease. But the problems with NSAIDs, we discussed that, GI bleeding, high blood pressure, adverse effects on the kidney, especially as you get older, and increased risk of heart disease. So when you're young, we are more comfortable giving it. As you get older, we really don't like this drug or this class of drugs, naproxen, Vimovo, Aleve, indomethacin, etc. Steroids, mostly we use it when you have one or few swollen joints. When the elbow was swollen, it was aspirated and steroids were injected. We do it commonly for the knees, for the ankles. That gives a relief of symptoms by the process of removing the fluid, but also by steroid injections help it take care of the inflammation. And many times, you don't need any other therapy. The injections itself help get the disease under control. Now, some people take oral and injectable steroids, which are not really recommended for spondyloarthritis because you need much higher doses, and the side effects when you use high-dose steroids are a problem. Weight gain, worse psoriasis, especially when the drug is stopped, diabetes, hypertension, cataracts, infection, hip arthritis, where the hip bone collapses and causes problems. So we try to avoid steroids, especially in spondyloarthritis. We don't, and when we use it as injections into the joints. The conventional synthetic DMARDs are usually these three drugs are used: methotrexate, which is given once a week, either as tablets or injections. Leflunomide, a tablet a day. Sulfasalazine, a bunch of tablets a day. And it's usually the first-line therapy for moderate to severe disease involving the hands, feet, or the legs, the joints, the peripheral, what we call peripheral arthritis. If it's predominantly back pain and stiffness, then these drugs are not effective. So that's why it's not given for primarily axial spondyloarthritis or ankylosing spondylitis. Trouble with these drugs, there are side effects. Talked about mouth sores. It can cause liver function abnormalities. Sometimes can cause diarrhea. So it needs blood monitoring, especially in the first 6 months. And then subsequently, if everything is great, the drug disease is stable and the disease is doing good, then you don't need to do it every month. You can do it every 2 to 3 months. But it needs some kind of a monitoring. The newer, tablets, the targeted synthetic DMARDs, the one that is available is apremilast or Tesla, is again given for mild to moderate disease, moderate to severe disease when the other drugs have not really worked. It's useful. The data on the spine has not been published, but the study was negative, and so it's not very useful. But it's useful when you have enthesitis, hand and feet arthritis, psoriasis. The drug does not need any monitoring, which is a good thing. And the side effects, in the first few weeks, you can have some diarrhea, but then it settles down. It can also cause some weight loss, which some people think is a good thing. And then the biologics. And these are, you saw the pictures, big protein molecules that bind the inflammatory molecules and take it away, and so the inflammation comes down. And the most important ones are the drugs that block TNF. So we have etanercept, which is Enbrel, infliximab, which is Remicade, and then Remsima, which is the biosimilar. Adalimumab is Humira, Golimumab is Simponi, and certolizumab is Cimzia. So these are the, once you fail the other drugs, these are the drugs that are usually given. The other drugs that are available are IL-12/23 blockers, ustekinumab or Stelara, and IL-17A blockers, secukinumab. And these drugs are very effective for skin disease, for back, especially anti-TNF, for back disease and joint disease. It prevents joint damage. Side effects are uncommon, especially after you screen for any underlying autoimmune disease or infection. But that's what we're concerned about: infections, especially in the skin and in the respiratory tract. Rarely you can have autoimmune disease, lupus-like disease, and demyelination, so-called drug-induced MS, and worsening heart failure. So if you have very severe heart failure, then it's best not to take these drugs. You have to pre-screen for infection. You need to have your immunizations up to date, and generally frequent blood tests are not required. But the other things, protecting yourself from infection, getting your immunizations before you go on the drug would be a good thing. Once you're on the drug, the immunizations are not that effective, and it's not recommended that you take live vaccines like the zoster vaccine, because when you're immunosuppressed, when you take a live virus, it may cause more problems. Ustekinumab or Stelara is another drug that is very effective for skin disease and peripheral joints. Not so much maybe for the spine, that we're still waiting for good data on it. Prevents joint damage. We always pre-screen for infection, but not that much of a problem. You need your appropriate immunization and blood tests. And for secukinumab, the newest kid on the block, just approved last week for psoriatic arthritis, and I think ankylosing spondylitis, and was already approved for psoriasis last year. And it is effective for skin, joints, and spine, prevents joint damage. Rare side effects are mainly candida infections, oral and esophageal thrush. Can take an antifungal and cures it quickly, so not much of a concern. But if you have Crohn's disease, it can get worse, so it's not recommended if you have Crohn's disease. Should, again, pre-screen for infections, get your appropriate immunization, and once again, frequent blood tests are not required. And lastly, there is also a concept of treating to target in psoriatic arthritis, not so much in angst because it's hard to define a target, but that would probably come up soon. So this is a state that both the physician and the patient together would decide to say, okay, my treatment, the goals of my treatment is to reach this state and stay at that state so that joint damage is prevented. And for psoriatic arthritis, we have criteria. It's not important to go into the details, but 7, you have to satisfy 5 out of 7 to be in this state of minimal disease activity. I want to highlight the 3 of the things are patient reported: patient pain, patient global, and a questionnaire called the HAC, which many of you complete whenever you visit your rheumatologist. And we look at the joint, skin, and the enthesis and come up to a conclusion whether you are in so-called minimal disease activity or not. If not, it's good to try to achieve that state. And considering the other things that happen, infection, side effects, etc. And the trial was done to show that if you target your treatment to reach this state of minimal disease activity, you're more likely to have a better outcome. And the problem, though, is that although the outcomes are better, there was higher side effects and higher use of biologic therapy. So that this approach may increase costs. So finally, what I want to talk about is also how do you get, how can you ensure that your treatment, especially with biologics, once you're on, at that stage that you have severe disease, now you're on a biologic, how can you remain on that therapy? We don't like to change therapy too often. And over the years, what we have realized is that drugs stop working after some time. So is there something that we can do to prevent this from happening? So in psoriatic arthritis, what has been shown is that if you lose weight, your drugs become more effective. If you quit smoking, the drugs are more effective. If you take your medications regularly, especially with the biologics, because they are huge proteins and your body forms antibodies to it. So if you miss doses and you stop and start, inadvertently, or lack of compliance, or maybe because you had an infection and didn't want to take it, and if that keeps happening quite some time, and if you don't take it regularly, your body is going to form antibodies against a drug, and the drug may not work, and you might then have to switch to some other drug. So compliance is important. There is also a belief that and that is data to show if you take a little bit of methotrexate or leflunomide or sulfasalazine, along with your biologic, it's going to work much better in the long term, especially methotrexate. So my patients, I encourage them to take 6 tablets of methotrexate every week, even if they don't need it otherwise. This helps the drug work better. And maybe if you come with your physician, if you can define a target and a goal, and like a goal that I talked about, and ensure that whenever you see the physician that you're reaching that goal. If you have a lot of joint damage, it might be difficult, but especially in early disease, if you can reach that goal and your treatment is targeted to reach that goal, and you take it, if you treat to target, then you're going to have much better long-term outcomes. At least that's what we think at this point. So I guess that's all I have to say. What I've done was to go through what psoriatic arthritis is and what causes psoriatic arthritis, and the current thoughts about the medical management and how we can get better long-term outcomes for patients with psoriasis and psoriatic arthritis. Thank you.
Any questions for Dr. Chandran? Oh, yes.
Sure. Sure.
Hi, Dr. Chandran. I'm Natasha. I was your patient in Toronto.
Oh, hi. I thought I saw you somewhere. Yeah.
I live up here now. And I think that I'm going to wait for my question. There's a question and answer here.
Right? Yeah.
Yeah.
Mm-hmm.
Okay, so I'll wait on it. You'll be around.
Yes. Definitely.
Okay, thank you.
I still remember Natasha. She screamed so loud when I gave her an injection 5 years ago. Yeah.
You mentioned that the biologics help to contribute factors. What kind of improvement of symptoms do you see? Like, how dramatic is it?
So the biologics have made a huge difference, and the disease is heterogeneous, and so some patients have a dramatic effect, say within hours, within a day or two, especially with psoriasis, the visible psoriasis. So for example, we had in the meeting today in the morning, one of the newer drugs for psoriasis, which is not yet in the market, with patients with bad disease, they give one injection, and the next day the skin is clear, and they were saying that you can see all the scales on the bed, but the skin is clear. So very dramatic changes can happen, but some take longer, and so we generally wait at least 6 months before we're saying that, oh, this drug is not working for you. And so we're looking at improvement in the skin, we're looking at improvement in the joints, and if there is back disease, which is inflammatory, then we look at improvement in all these symptoms. And so the minimal disease activity criteria that I was showing tries to encompass all that from the patient perspective, the physician's joint count, enthesitis, skin disease, to see that all that improves. So I would say most patients, there are many patients who don't respond. So in the clinical trials, the so-called 60% improvement, or 20% improvement, ACR 20, was seen in about 60%. So in our own cohort, significant improvement was seen in about 70% of patients after about 6 months. So there are patients who don't respond, and there are patients who have an immediate dramatic improvement. And so it's not like you're guaranteed a response, and that's why we have so many drugs, and one failed, we try another one. If same class, 2 drugs fail, then we say, okay, let's go to another class of drug like the IL-17 blocker, which is not an anti-TNF blocker, because not all patients, although we call the disease psoriatic arthritis or ankylosing spondylitis, the underlying mechanisms that reach that state may be different, and so we have to try the other drugs. So you might ask, why is it trial and error? Can't you do a test to say which is going to work for me? That's what. Yeah, but.
So if you were to take a biologic and then go off of it, could that alter your course of?
So if you don't, so if you're, that I meant in saying that, we are for so-called targeted therapy, right? Which is a drug for you. There is research going on, and hopefully down the line we'll have, okay, you come with the disease, you do a test and say, this is a drug for you, and that's going to work. We are not there yet. So that's one thing. The other thing I was talking about, being not non-compliant, and for various reasons, is if you have a drug and it really works for you, and you've gone into remission or low disease state, or you're doing very well, and then if you don't, the problem is that when you don't take the drug regularly after that, for whatever reason, then you're likely to have what we call secondary failure. You did very well, and then the drug stops working for you. So how can we prevent that? One of the things to do is to take your drug regularly, especially these protein molecules, and then a little bit of methotrexate may be useful too. So that's what I was trying to get at. You're welcome. Sure. So the reactions to biologics, you can have, allergic reactions. That's methotrexate is not going to prevent that. It's mainly to prevent the antibodies from developing against the drugs. So how it manifests clinically is that your drugs, usually when you take the injection, you feel better and everything's good, and you take your injections regularly and everything stays good. When you develop antibodies, what happens is that you keep taking the drug, but you can see that the skin is getting worse, so you have more joint pain or back pain, and in spite of taking the drug is not working. You can test for the antibodies. It's hard to do. We don't, there's no lab we don't have a lab that'll do it free of cost, and it's hard to test for it. And if you test for it, you can find antibodies against the drug, or if you look for the drug levels in your blood, it's much lower than what it should be, indicating that something's just taking it away. And to prevent that, methotrexate has been shown to be helpful. In rheumatoid arthritis, the other autoimmune arthritis I talked about, it's definitely shown to be very helpful. Now we have data on psoriatic arthritis, and more recently in ankylosing spondylitis also, that taking a little bit of methotrexate keeps the drug working for a long time. So that's why I'm talking about it. Go ahead.
I wonder, there's this blood test for inflammation, CRP. What's the relationship between that and symptoms?
Right, so CRP is a generic test for inflammation. So you get a flu, it's up. If you have a pneumonia, it's up. And if you have rheumatoid arthritis, it's up. The trouble with CRP and spondyloarthritis is that even if you have active disease, inflammation in your SI joints or in your peripheral joints, the CRP may be normal. It's not a good marker for inflammation in spondyloarthritis. And that's where a lot of late diagnosis, one of the other reasons for that. You go to your GP and he does the CRP, it comes back as negative, and then he says, well, there's no inflammation, the back pain is just mechanical. So CRP is not a good marker for inflammation. It's a prognostic marker. So if you have ankylosing spondylitis or psoriatic arthritis and your CRP is high, it means that you have a worse disease compared to normal CRP. So, and people who have elevated CRP respond very quickly to treatment too, because the inflammation levels are very high. So that's where the CRP is very specific. It's a marker of prognosis severity rather than a diagnostic marker, and it may correlate with your severity of disease, but not always. in majority of the time not. So that's a problem.
So if there are any more questions, Dr. Chandran will still be here afterwards, so that there'll be
Just a quick one. In terms of the CRP factors, mine went up to 36, and it was quite elevated for some time. And during that time, I basically got to a point that I stopped moving,
Right.
right? And so, I mean, everything is so stiff and so incredibly painful at that point, and you're trying to get it down and everything. But what does that actually mean in terms of like in terms of your heart and everything else? Because that's a fairly high CRP level.
Yeah, so the CRP is important. It's a marker of inflammation, not for everybody, but if you know that your CRP goes up with your disease and you don't have a flu or a pneumonia or a urinary infection, then it's a marker of that marker is correlating with your disease, right? So it indicates that it is active, especially if you have symptoms, you're stiff, and then and you treat the disease. On a long-term perspective, I would say if your CRP remains high or for a long time, that's more problematic than it being elevated for a short while because of a flare. So the overall game is management is to try to get your CRP as well as your symptoms down to normal, so that it prevents joint damage, joint fusion, as well as heart disease. If you have persistent inflammation, which is CRP is a marker, you're more likely to get more cardiovascular disease, and which has been shown in by research too.
The one issue that I have is like in a situation like my father's, basically he bled to death, right? His vascular system just kind of collapsed on him, right? And so this is, I'm just questioning it because I'm trying to understand how much can your veins actually handle in terms of the expansion and contraction that happens with this type of, I've got AS, right? So I'm just trying to understand.
So AS does not cause problems with the vein. It does cause accelerated atherosclerosis, meaning that heart disease that tends to happen later on in life tends to happen sooner and can be more extensive. And so you have higher, at a particular age, you have more heart attacks and strokes in this population. So I understand your dad had more heart disease.
He had asthma.
So that.
But my grandmother had AS, and we've just got this throughout the family, right?
So AS is associated with more vascular disease, and treating it will hopefully prevent. We're not shown that yet, but we think that would prevent in the long term. Yeah.
Well, thank you, Dr. Chandran, and we'll have some opportunities a little later for some other questions if you have some. Thank you. Before we take our break for refreshments, we have a physiotherapist that's joined us, and she's going to speak a little bit about the exercise regimen. And I understand that she's tired of you sitting around, so there's going to be there's a participation exercise, I believe, that might be going with it. So it's our pleasure. Would you please welcome Karen Sonji?
Firstly, I'm going to get everybody to stand up because you're probably all getting pretty stiff. And I was supposed to basically lead an exercise break, so it's going to be hard for you to see me behind this podium, so I think what I'm going to do is I'm going to stand out there and just try and yell really loud, okay? All right, so let's just start moving. Let's just start walking because we need to get the blood flow through. If you're not aware, we should be trying to get up every half an hour when you're spending time sedentary. Either long periods of time lying or sitting are not good for our overall health. We were just talking about cardiovascular disease. When you're sedentary and not moving for long periods of time, especially these big muscles down through here, your blood sugars go up. So that increases the risk of developing diabetes down the road. Your blood pressure goes up. Again, the risk of heart disease goes up down the road. And we, as a population, being at higher risk for this, best thing we can do to help fight that risk is exercise. So both cardiovascular training and strength training. Movement is life. You need it to help keep you limber, to help keep you from getting stiff, to help decrease even your disease activity levels. Okay, so I'm going to show you a few exercises that are, or stretches I should say, that are good for anybody
Refreshments are outside, everyone. You can plate up and come back to your chairs if you want to eat in here. And we'll have a short break, and then we'll continue on with the rest of the presentations. They usually do excellent food in this hotel. If we could find our way to our seats, we're going to begin in just a couple of minutes.
Just let me make sure that it's working, because it's not showing on the screen.
Well, welcome back, everyone. We're going to continue on with our evening's presentation. It's my pleasure. It's my pleasure to introduce Ewan Sim, who's going to talk about a new app that has been created for ankylosing spondylitis health, Storylines app. It's been done in concert with my own organization, the Canadian Spondylitis Association. So, if we could please welcome Ms. Sim.
Thank you, Don. Hi everyone, my name's Ewan and I work with a company called Self-Care Catalyst. The reason I'm here today is to present a new digital self-care tool that we've developed in partnership with the Canadian Spondylitis Association. So about last year, we reached out to the Canadian Spondylitis Association based in Toronto, and we actually had a bunch of patient-focused groups where we spoke to patients living with ankylosing spondylitis, and they told us that there's so many things that happen when I'm dealing with with my condition. So I see my doctor every 3 months or even every 6 months. And every time I go to my doctor, I forget what has happened in between each visit. So there's so many things to keep in mind, whether it be it symptoms, medication, and even, your daily moods. So we talked to all these patients and decided, why not let's create an app, a customized app that can cater to the needs of patients who are dealing with ankylosing spondylitis. So from all of the talks that we had previously today, we hear that managing your own self-care, especially for AS, is not just about taking medications. There's so many other dimensions of self-care when it comes to AS. It could be, dealing with making sure you're doing your exercises, your stretches, taking care of your nutrition, making sure you're at the top in terms of your emotional health. So taking all of that into aspect, we built a very multi-dimensional self-care tool for managing AS. And I'm going to show you a very quick demo today so you know how to use it and can make the most out of it when you download it later on. So the different tiles that you see on the screen here are the different health tools that you will be able to use when you download the app. So it's available on the iOS App Store as well as on Google Play. It's a free app, so you can feel free to download it. The most practical part of the app we hear from a lot of our users is, of course, the medication tracker. We hear a lot today that staying adherent to your medication, making sure you're taking them as prescribed, on time, on schedule is really important. But sometimes life gets in the way. So we hear from a lot of people that we speak to that I forget sometimes, whether it's a daily medication or maybe you're taking it bi-weekly or even monthly. So with the medication tracker on this tool, you can actually set reminders for the different medications that you have to take. So it's really easy to add a medication, so you just type in the name of the medication you have to take and set the time for taking those medications. So on your actual device, whether you're using a tablet or a phone, you can actually get a notification that it's time to take your meds. But the great thing about that is that it's not just a reminder. The thing is that we want to empower people to keep track and monitor their health so that the next time they go see their doctor, when they're sitting in front of the doctor, they are armed with the information they need to participate more actively in making treatment decisions. So each time you get a reminder, you can actually record if you've taken your medications or not. And you're actually building your own history of your medication activity, whether you have been staying adherent, if you're missing your medications. And why is that so important? Because everything that you record onto the app gets summarized on a page called My Storylines. And this is where your story really comes true. So you can look at your medication activity, you can compare that with your symptoms, how your symptoms have changed over time. So by recording all of that information on one page, you have a summary of everything to do with your health. So the next time you see your doctor, you won't have to forget what happened 3 months ago, whether your medications were working or if you have to actually ask for a new medication. So going back to the health tools screen, let's quickly take a look at the symptom tracker. With the symptom tracker, you can enter any sort of symptoms that you want to track. It could be related to your AS or any other conditions that you might have. The great thing about this tool is that it's very customizable and personalized for your own needs. No two people with AS might have exactly the same experience with their journey, so you can actually add custom symptoms. So imagine if you have difficulty breathing. So you can add that into your symptom tracker. And every day you can rate your severity of your symptoms from a scale of 0 to 10. And on top of that, you can rate what is the impact of your symptoms on your everyday life. So maybe your symptoms might not be very severe, but think of this as your own quality of life scale. How is it really impacting your day at work, at home, or even with your relationships? So as you record all that information, you're actually building an easy-to-read visualization. It's a graph that gets built over time to see how you have changed, or maybe if you're getting better. And this is the information that you can actually bring to a healthcare provider. So let's look at daily moods. We all know that emotional health is such an important part of your overall health and self-care, but sometimes it's often ignored. So this is actually one of our most used tools in the app by our users because I think it's very visual and people really see the benefit of that. So by being able to track your moods on a daily basis, you can actually see if it's it's an impact of your condition or maybe a new medication that you're on. So we've actually had patients tell us that I never thought that my mood could have such a big impact on my overall health until I see it visualized on a screen. So being able to see all these changes and being able to see it built for you in front on a calendar can actually help you take action, whether it's seeking help or maybe talking to a doctor about it. We have a daily vitals tool as well for anyone who wants to track different types of vitals. I won't go into too much detail about this, but you can track your weight, your height, blood pressure, and things like that. There's an appointment calendar for you to put in any appointments that you're going to, and even a journal. So we did a whole bunch of research around journaling for people dealing with chronic conditions, and it's actually really therapeutic. We did some research and selected some questions here that are meant to be really positive. So a lot of people dealing with long-term illnesses might feel like I'm not really accomplishing a lot. Sometimes they have to take time off work, but all these by focusing on all these negative aspects might not be good for your overall health. So we want people to focus on accomplishments, what they're thankful about, so that, like, for example, there's a question on gratitude. So people might not know what to journal about, but using this tool, it gives you an avenue to express yourself. Another cool feature is what we call the healthy doses tool. So some of our users, it might not appeal to everyone, but some people do feel this to be really interesting to help them engage with the app. So when you're feeling down, you can come here and get daily snippets of optimistic quotes and images to help you feel better. So one huge thing that we actually heard from a lot of patients that we interviewed in developing this tool is that fatigue is a huge part of dealing with AS. So we built this fatigue tracker so you can stay on top of your daily energy levels and plan your days that way, and taking notes about what's making you feel fatigued or what's actually helping you feel better. So by being able to record easily your daily energy levels and your fatigue levels, you can actually see that as well on a calendar. And this is interesting. It's a routine builder, and the reason we built this routine builder in the app is actually based on some of the feedback that we had from patients. Some people are telling us that, I stand all day at work and I have to set a reminder for myself to maybe just take a break. Otherwise, I might, be feeling worse by the end of the day. Or maybe for some people that sit all day at work, if you're working in an office environment, they often forget that, you have to get up to, do some stretches or do some exercises. So we wanted to build a tool where people can actually set reminders for themselves to build these healthy habits. So you can add different habits to your routine and set reminders that way. And each time you get a reminder, you can record if you've completed or skipped those different routines. And it could be taking a stretch or going for a walk, and see how you've been sticking to those healthy habits over time. And again, all these inputs into the app get summarized on a page called My Storylines. You can print this, share this with your doctor, or bring it with you the next time you see a doctor, so it's easy for you to recall what has happened in between each visit that you go. And we hear today as well that for people with AS, sometimes they experience other types of conditions as well that's related to AS. So for example, it could be IBD. And what's great about the tool is that you can actually customize and personalize it for yourself. So we have this thing called a tool library where you can actually go in and select different types of tools that you can pick and choose and build the app so that it's personalized for your own needs, even though you might be an AS patient, but what if you have other conditions as well or other needs that someone else doesn't have? So for example, in the tool library, we have a food diary that you can actually download and put into the app. So that allows you to take pictures of what you're eating and recording any triggers. So for example, somebody who has inflammatory bowel disease might find that really useful in identifying what's causing them flares. Another one that's interesting is a stool diary. So for example, with the stool diary, I'm just going to add it to my screen. Many people actually find this interesting, especially if you deal with any sort of GI issues, is that you can actually now record. It's based on a Bristol stool chart. Don't worry, it's not asking you to take a picture of your stool. So you just record it in a, this is something that can really help your doctor to determine, whether your treatment needs to be changed or, if something else needs to be looked at. And how many of you here wear like a Fitbit or a Jawbone or use some sort of connected health tracking device? So a few of you, yeah. And that's actually consistent with what we heard when we did our focus groups, especially with people with AS, is that a lot of them actually have started wearing Fitbits and devices like Jawbone because they want to remind themselves and motivate themselves to stay active. So AS Health Storylines allows you to actually connect with those devices that you wear, and you can import those information into the app. So it's not only collecting your self-reported data that you're putting in, for example, whether you're taking your medications, what your symptoms are like, but now you can actually compare that with the data that's being passively collected through your wearable devices. Or if you have diabetes or any other health conditions, we also connect with blood glucose monitors and things like that. And that's a very quick overview of AS Health Storylines, developed in partnership with the Canadian Spondyloarthritis Association. It's a free tool, and feel free to download it on the Google Play or the App Store. Are there any questions? AS Health Storylines. Yeah.
When you use this app, are you opting to share any of this information with third parties?
Yes, so that's a good question, actually. So when you download the app and you go through the registration process, we actually inform our users that all your personal information will never be shared. So we don't share any personal information, nor do we want to collect that personal information. But other types of information that you put into the app, for example, what your symptoms are like, what medications you're on, we de-identify that and share it on an aggregate level. So we do some research with that and build up patient journeys, and that's where the patient stories come in. So that way we can work with healthcare providers or even different types of healthcare companies to inform them about what the real experience of patients are like. So it's never going to be on a personal level. So for example, we only share data such as 90% of patients on such and such experience these symptoms. Yeah?
So I downloaded this like about a month ago.
Okay.
One thing that I was wondering if you guys were going to fix is the medication tracking.
Mm-hmm.
Don't add in an option for like bi-weekly or every 3 weeks, since biologics are sometimes just monthly.
Yes. Actually, that's a really good point because we had the exact same comment come through one of our App Store review pages, and that's something that we're looking into. We built in monthly reminders, but not yet bi-weekly, but that's going to be an upcoming feature.
Also, as you know, the fatigue is a big part.
Mm-hmm.
Does your information need to be added every day at that time, or can you skip back 3 days ago, this is what I did and how it was done, and this is the medication I took and at what time?
So there's some information in here that you can actually add for previous days, but some of the information you actually have to add on that specific time because we don't want people to forget that it's actually happening. Yeah. Any more questions? Okay, great. Oh, there's one more. That's a good question. So actually we have a feature for that. It's called Circle of Support. So we hear today from our patient speaker and even from some others that having a support network is really important when it comes to managing a long-term illness. So with the Circle of Support feature, you can actually add a caregiver or a partner or somebody who you met at a support group. Just put in their email address and choose whatever you want to share with them. So you can choose not to share your medication information with them, but only certain aspects of what you're tracking. Great, thank you.
Thank you very much. Does anybody know how I can get on with this phone? It has no cord. It's really a great. Just take about 1 second here. I have to switch a computer over. This much I can do. Is there a power cord for it?
glad you're doing that.
Ladies and gentlemen, it's my pleasure to introduce Cheryl Cohen, who is the president of Arthritis Consumer Experts. This is a lady who has advocated on behalf of spondyloarthritis patients for, a week or two. We've known each other a long time. So she has some great things, I think, to talk to us about advocacy and all. And there are, I'm sure that it'll be informative about where it is we're going as far as our disease is concerned. So please join me in welcoming Cheryl Cohen.
Thank you very much, Dawn. You've just revealed that not only you are old, I am also old. It's really a pleasure, older, thank you. I like that qualifier. It's really a pleasure to be here with you this evening. As Dawn said, I've been, while I am a rheumatoid arthritis patient, I snuck in the back door when you guys weren't looking. We are all brothers and sisters in a very interesting journey with autoimmune disease that really focuses on attacking hands, feet, hips, spines, knees, jaws, you name it. This group of diseases that is represented by the CSA and all arthritides that are represented by Arthritis Consumer Experts take a toll on a person's life, and it's how you look at your disease and how you go about managing your own issues and your own experience. Believe it or not, offers tremendous help to others, particularly if you're willing to share what that journey is like. So it's very much a privilege to be here tonight. I was diagnosed 27 years ago. I was an Olympic volleyball player. I went from being an retired Olympic volleyball player at the age of 26 and was wheelchair bound in about 6 months. So my disease onset was swift and hideous. And it was with the help of the rheumatology community, which is an incredible community in Canada, so talented, so dedicated to their patients. And like you figure it out. Like you did yourselves, you figure it out. So it's really my pleasure to be here and to talk to you about fighting for fairness in reimbursement access. So you've heard personal stories here. That was a great overview of an app. Our organization has also built a couple of apps a number of years ago. It takes all kinds of tools and partnerships to make a difference in disease. So I'm happy to tell you about a tool that we developed quite a number of years ago and how it has helped change the landscape for reimbursement access in Canada. In everything that we do in ACE, we disclose our sources of funding so that when you hear, see, feel, touch, or experience anything that the organization I lead is doing, you have an opportunity to make an assessment about whether we're influenced by those people or organizations. So there's the long list of our funders. We are so thankful that they provide us with their support, but they in no way influence our agenda. It is done, that is done by our membership and by our senior management team. So you can see before you here a very brief agenda, and it's just to tell you a little bit about who ACE is, the organization I lead, to talk to you about fighting for fairness for reimbursement access. Who knows what reimbursement access is? Raise your hand. Who knows what the topic is? Okay, let me boil it down for you now. When you go and get an expensive medicine, and many of them in our disease states are expensive, there's either private health insurance if you've got that given to you or provided to you by your employer. Some of them give it to you whole and is fully paid for by the employer. Some you have a copay, or you have a provincial drug plan. When you go to with these expensive medications, someone actually, not us, determines whether you get that covered or not. So that's when you hear the words reimbursement access, it's really about whether something is accessible to you through a formulary or not. And this topic has been one that has been, to say the least, a hot topic in our community for a number of years. Then I'm going to tell you a little bit about informed advocacy. I'm old enough now that I can muse when I give a talk, which is really, really fun. You know, when I was a young whippersnapper, I just pretended I knew stuff. Now I can actually muse because I've been through the trenches, have learned quite a bit from my colleagues in arthritis, both at the research level and clinical, and as well from my fellow patients. And then we're going to have time to chat. So ACE is an organization, ACE is an organization that is really what we consider ourselves the hub of 5 different arthritis organizations in the country. I don't know where the, oh, there it is. And you can see here that we have 15,000 members across the country. So we started first, and so thus we're the biggest. We go from coast to coast, and everything we do is fully bilingual because we do have 2 languages in this country. And our largest piece of our membership is Ontario. Quebec is second, BC is third. So our membership spread is very much as it is in Canada. We talk to 100,000 people every month, 6 to 8 times a month, whether it's in print, online, through our email, or through our social media platform. We have provided, I think, really good support, moral and in-kind support to CSA and the others in our community from the time that they have formed until now, and we're certainly thrilled to be able to do that. These slides are kind of out of order, sorry. This is how we reach those people. So we do apps, we have websites, we have a news aggregator site, we have emails, we have measurement tools, we have medication guides, we have all these types of tools and education programs that reach out to our public. So it is through these vehicles, through this platform, and they're not all up here, but there are 11 communication channels that reach those people. One of the reasons we built them, all of those things, and one of the reasons we founded in 2000 was because I was participating as a volunteer in a national research group called the Canadian Arthritis Network. And from my research and rheumatology colleagues, I began to hear about biologics and learn about what they were doing to people in clinical trials. Not bad, but good. There were stories of people getting out of wheelchairs and literally walking the next day. For some, the response hasn't been as good, and it's gradual and slow. For others, they truly have been miracles. So in the research setting, I started hearing about these things. I thought, wow, that's amazing. And I also heard about their sticker price, that they were going to be expensive. My background before I got RA, and it's still my background now, is marketing communications. So I thought, okay, governments are going to get these files from the manufacturers, the medicine makers, and they're going to see the sticker price, and they're going to have sticker shock. Because nothing like them in arthritis had been before them. Everything else were all of these other medications were several $100s a year. These were $15,000, $16,000, $18,000, $20,000 a year. So we kind of peered into a crystal ball and thought, well, this is going to be shocking to them. So what we thought we would do to prepare them was to educate them. We wanted to tell them about the severity of the disease. They knew nothing. Provincial healthcare systems basically didn't know, payers that is, didn't know anything about your disease. They didn't know anything about my disease. They didn't understand that the cost of these medications was clearly going to be offset by keeping people healthy, out of the healthcare system, out of hospitals, out of emergency rooms, on company payrolls, and being productive, healthy citizens in Canada. They didn't understand that that is what these things could do. So from 2002 to 2006, we basically went back and forth across the country, educating the grassroots, educating government, educating payers. And we knew that there was going to be a problem. And the first provincial reimbursement came in 2002, but it took 2 solid years of talking to them about it. Then from 2007 to 2008, as they began to get listings for ankylosing spondylitis or axial spondyloarthritis, psoriatic arthritis, and a number of other diseases, guess what happened? They stopped listing these drugs because they figured, well, we covered RA, and they just got out of the game of listing. So we went to them, again, crossing the country, and by this time the CSA and others were becoming very active, and we began to partner together. We launched a discrimination campaign because no amount of talking to them was actually helping them to understand that people were falling by the wayside. They were not receiving the treatment that they so desperately needed. So we thought, okay, if cancer's getting their high-end treatments, appropriately so, by the way, this is not pitting other diseases against each other. This is about lifting AS, PSA, and RA up to the level of everyone else. Because before 2002, we were down here. They spent virtually no money on our medicines. So we argued for equity. We argued the cost-effectiveness case and tried to explain to them again that ankylosing spondylitis happens to people, it can happen to people when they're 18, 19, 20 years old. That people with AS go through years of potential missed or undiagnosed state, and that the effects of that disease cannot be reversed even by excellent therapies like DMARD combinations or biologics. So the discrimination campaign, you can see there the definition of discrimination. It's an act or a policy of unfavorable treatment based on prejudice. One of the things that makes governments, both elected and public service, stand up and take notice of a community, whether it's a disease community, a chronic illness condition, whatever you want to call, if it's the get a stoplight in my community committee. One of the things that helps is to be provocative and to actually use language that makes them pay attention. And with government, discrimination is certainly one of those words. We were fighting for 600,000 people. So along with being provocative, I think in a respectful way, we needed to tell them how big we were. Your set of diseases represented in this room and my disease combined is about 600,000 Canadians, give or take. I'm looking at the doctor, and he'll correct me if I'm off by 10 or 20. But roughly, it's 600,000 people living from coast to coast with the diseases that are listed there. We were really fighting for the right to choose with our healthcare provider the therapy best suited to our disease biology, which is distinctly different from patient to patient. And that was illustrated when our doctor was telling us about the difference of CRP and what it means from one patient to another. For one patient, if it is parallel with disease activity, it could be not a bad marker. But in others, it's not a very effective marker. So we wanted to really underscore those points. Once we launched the discrimination campaign, we had to actually quantify it for them because we still weren't seeing reimbursement listings made for these diseases with the drugs that were available to treat them. So we did what cancer had done before us. We created a report card. We decided to grade our governments across the country, province to province, on how they treated people with AS and PSA, as well as RA. And you'd be surprised what happens when you get a report card. Holy smokes, people start to pay attention, especially when you're not at the top of the report card. So the key audiences for this report card, of course, were the provincial ministries of health and their public service, but also people like us. Because when you're sitting in your clinic and you're wondering why your physician isn't prescribing those things you've read about or seen commercials about, you might think your doctor is not doing their job, and nothing could be further from the truth. Sometimes it's about ability to pay. And a lot of people, in fact, I would argue 98% 98%, that's not a scientific number, I'm just guessing, 98% of us couldn't afford a drug that costs 20 grand a year. Am I right? Yeah. It's unattainable. So to know there's something out there that can absolutely change or save our life and not have access to it through a formulary is really, really awful. So when we launched our report card, there were people with ankylosing spondylitis across this country who couldn't get access. We partnered with the Spondylitis Association and with others who were interested in the campaign, and the partnership was really important. Although we have quite a large number of people or members who are people living with some type of spondyloarthropathy, there is an association that has it in its name. So seeing those two groups partner was a very important part. We had national, and it's called PR for GR. How many of you have heard that term before? Yeah, so you do public relations and get an issue out in front of the media to get GR push, and GR means government relations. So if you put something out in the public press, you capture government's attention, so it's PR for GR. So we highlighted the disparity. We showed the length of time it was taking for governments to review and consider whether they should go on formulary. And we also told many, many stories about what was happening. I like the patient journey piece and being able to piece those together. We were doing that every day in the paper. You can see here we started in November 14, 2007, and take a look at those headlines, everyone. So we talk about two-tier, and we launched this in Saskatchewan, which is the birthplace of Medicare in Canada, which we thought was the perfect place to talk about discrimination. And then later, we had lots of great pickup. I'm just giving you some of the big headlines. In January, we went to Ottawa, we went to Parliament, we went inside Parliament, and we held a press conference with a human rights lawyer, with a leading clinical researcher in the country, myself. And I'm not kidding you, we made rain happen with that event, because we went off then to a little, I think we went across the street to like Milestones or something, and we holed up by a table, and we must have fielded 50 media calls within an hour. It was unbelievable. So we first talked about discrimination in Saskatchewan, then we launched in Ottawa. And you can see there, and guess what happens? ACE applauds Saskatchewan government and calls for more work to be done. We launched this in Saskatchewan, and 4 months later, patients had coverage. That's what that tool did. There's a continuing saga of, so we were relentless with the media, and it takes resources, but more importantly, it takes creativity, it takes provocative language, it takes connections if you have them, but really it is just dogged determination that made this campaign run. So this is sort of the narrative here. In the first year after the launch of the report card, look at the provinces that decided to add biologics for SPA and other forms of autoimmune arthritis. We then kept that report card going. It is in its 9th year. So just last month, we put in the mail our 9th annual arthritis, and now we call it not biologics, we now call it arthritis medications report card, because it's now tracking 3 different types of medications. There's now subsequent entry biologic, which you cannot call a biologic, and there are targeted small molecules, which are new sort of pills that are showing through clinical trials to be as effective or very closely effective as a biologic. So this is just a quote from Dr. John Esdale. He's the Scientific Director of Arthritis Research Canada, which is located here in British Columbia, but has centers in Quebec and in Alberta. And John is not someone easy to persuade to get a quote. He really believes in this tool, and I think if you talk to rheumatologists across the country, they would agree. It hangs in pretty much every bureaucrat's office in this country if they are in the Ministry of Health. So when they get this, it goes up on in their little cubicle, because they want to know not only where they stand from an objective point of view, but they want to know basically what diseases are being covered, what's happening. They actually see this as now a turnkey piece for their own news worthiness within their own hall. So quickly here to summarize this piece, the keys to success for this was, we were strategic. We didn't just go out there crying for reimbursement. We knew we had to educate them about the diseases first, because unless you tell them what the diseases are and you tell them the impact at the individual level, you are never going to convince them that an expensive drug is worth putting on a formulary. We created a public media campaign that, with appropriate resources, that was also appropriate for the subject matter. And it was, we achieved sustainability. So we kept that media and the topic in the media for over 6 months, which is quite unheard of if you've ever gone out to try to get media coverage. I think we had really good leadership, but more importantly, we had excellent support and partnership with the CSA and other groups. And then lastly there, in just 4 quick points about success, we thanked government. When you get what you want from government, you have to make sure to thank them, and thank them often, because they do represent us as taxpayers. We could easily swap places and have their job, and trust me, you don't want their job. You want them to do the best job they can for you, and you're an integral part of that. Over the next couple of minutes, to summarize, I was asked to say a couple of words about advocacy. And I don't like talking about advocacy unless we put the word informed advocacy in front of it. Because going outside and screaming at the top of your lungs that something is wrong, something should be done about it, you really have to know the subject matter. This quote has inspired me my entire life. Martin Luther King, for me, was the prototypical advocate. And he said, our lives begin to end the day that we become silent about the things that matter. Something matters to you, you cannot keep your mouth closed. It's that simple. And if you don't feel you have the ability to open your mouth and speak, find someone who will help you speak. So these are just a few words to you about what informed advocacy is. Informed advocacy is not just shouting. It's shouting things you know and know very well. It's about authority and about experience. And you have moral authority. It's not just talk and opinion, it's action-oriented. So it's being informed, being an expert, having lived experience, and acting on it. It really is about moral authority. And moral doesn't mean necessarily you're moral. Moral means you have ankylosing spondylitis or axial spondyloarthritis or psoriatic arthritis or some type of autoimmune arthritis. You have the moral authority to speak your experience and ask for what it is you need. Pure and simple. You're someone who has a keen desire to learn and get involved and be informed on the topic of discussion. You're passionate about helping other people live or deal with similar circumstances, and you're actually someone willing to devote their own time and energy to make positive change in their own life and for others in their community. I've got to tell you, I've been around way too long, and Dawn Bindon has been there with me. God bless you, Dawn, for doing what you've done for free, for people, forever. And there are others of you that I don't know or don't know as well, and it's that commitment to community that actually changes and saves lives. It's that simple. It's our brother and sisterhood together that makes a difference for people. It's someone who dreams and dreams big and has vision. Governments actually follow vision because governments often lack it, or they lack the knowledge to have the vision or to dream. And if you're all of these things, you're the best advocate for your vision. If you are all of these things that I've just said on the previous slides, that makes you a leader in your community. But people can have all of that and not make change, or want to go forward and make change. And sometimes it's because they don't have a big, loud gym voice like me. But you can find your voice and learn how to use it. If you stop and self-reflect and think about your commitment to yourself with your journey of disease, and you think about others joining you along that way, you can do it. If you're educated and someone's there to support you, and you have that knowledge, you have power, you will speak, trust me. And you can learn with your family and friends first. Those are the people, those bullet points there, that's where I started yakking first. I started talking to my family, started talking to my coworkers who said, oh, come on, let's go. And I'm like, okay, what part of I have rheumatoid arthritis and I'm sitting here in a wheelchair, do you not get? You know, you kind of have to help people along because they don't get it at first. It's a complicated topic. And if it's happening to you, then again, you have the moral authority to speak. Speak the truth, even if your voice shakes. Voice shaking is okay. I still give talks and I get teary-eyed, I get nervous, my voice quakes because I believe in it, because I'm passionate about it, and because I want to help myself. And if I help myself, I help a lot of other people. That's what a good advocate is. And you're not the only one. You can join your voices and make it a gorgeous choir. ACE and the CSA has sung beautiful music together for quite a long time. And we've helped others identify issues and determine what the impact those issues would have. But I think at the end of the day, someone who's an informed advocate, practicing an informed advocate, is constantly looking for where the action is. You're trying to go where there's change needed, not where, you know, you can sit back and kind of go, okay, we're done. We're never done, is the truth when you're volunteering or working in advocacy. The thing you've done here today by coming together to learn is actually community building. You're doing it right now. You're building a community, or you're making it larger. And I think a key piece of this kind of educational activity is building a common language. And it's education about the disease, speaking knowledgeably in front of your healthcare provider, that actually helps develop that common language, building consensus, making decisions in a transparent manner, and then even crossing disease boundaries. My mentors in the community were people with HIV/AIDS and cancer, because there wasn't anyone like me around. Like, seriously, when I said I was old, I really mean it. I got all kinds of tape and strings and things pasting this lines back. So those are just a few of my, I guess, pearls about informed advocacy and what it takes to be one, and how you build community and sustain it. So disease equity, in summary, in health research and healthcare systems is an ongoing challenge. This report card hasn't fixed a lot, in fact. It's fixed some of the reimbursement stuff, but changes still are taking place. Anticipating obstacles, we could see what was going to happen a year ahead, and we started planning for it. So as a community, you can start sharing what the challenges are and then thinking about ways to overcome them. Reporting on government's performance in healthcare is effective, and it does make positive change, and it actually helps win elections, believe it or not. Because since this report card was designed, developed, and sustained over the years, I go to meetings with politicians now, not related to arthritis, and they're standing there in these meetings, and they say, yeah, like we've done for biologics and autoimmune arthritis. They use our community as a huge success for them right across the country, which is really encouraging. And lastly, speaking out about wrong is the right thing to do, no matter how uncomfortable that might be. Wrong is never right. Right is always right. And it's such a great principle. So I encourage all of you to become more involved in the community if you're not, or if your level of involvement simply means you want to tap into the knowledge that is resident in the CRA, that's great too. But if you have a passion and you want to get involved, there are lots of places to get involved. And these are the ways that you can find me. And if I don't respond within that day, I generally am good the next day. And don't be scared like I'm stalking you if I reply at 2:30 in the morning. I'm kind of a night owl. So thank you very much, everyone. I hope you have had a nice session.
I never get tired of listening to Cheryl talk. And I always feel better after she's done it too, for that matter. We're going to take, we have some questions. Actually, we probably have quite a few questions, as I recall, seeing that list. So what we're going to do is take about 1 minute, and I'm going to move some chairs up here in the front. We have a microphone for our physicians and physiotherapists, and we're going to go through these questions. I'll get them to repeat them, and so if you had a question that you gave them, they're going to answer them in the next couple of minutes. So just give us about 1 minute to get some chairs up close, and we'll go forward.
Or we can hold the mic. You can alternate.
You just pass the mic back and forth.
Yeah, oh, okay.
Hello.
Do you want us to read the questions too?
Hello. 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 I think we'll alternate on the questions just because there's quite a few. So, Dr. Chandran, you want to go first?
Oh. I tried to put it into some sort of an order.
Hey, I feel cheated. The doctor's got a whole stack. Quick, write questions.
So I'll start with a PSA question. There's this question about osteoarthritis of the hands and psoriatic arthritis. The question is, would you describe in more detail the symptoms of PSA in the end joints of the hands? My doctor told me it's osteoarthritis, but I wonder if it is autoimmune. So psoriasis, patients with psoriasis can get a form of arthritis which is psoriatic arthritis. It affects the end joints of the fingers. Osteoarthritis is much more common. When you have psoriasis and you get the end joint arthritis, the question is it osteoarthritis or is it psoriatic? The psoriatic arthritis is much more inflamed, and so usually there is redness at the tip of the joints, but also the nails are particularly affected if that is psoriatic. So if the nail where the joint is affected is okay, then it's less likely to be psoriatic. X-rays, there are some subtle changes that can be looked at. So a rheumatologist would be best to differentiate between psoriatic end joint involvement or osteoarthritis. I hope that answers the question.
So I have, could a car accident trigger ankylosing spondylitis? I think that's something for the courts to decide. Is it possible? Certainly possible. As we heard about, there is this microtrauma phenomena that we know, we call it Kebnerization, where in psoriasis, you can scratch your leg and you can develop psoriasis in that area. I think the Toronto group has published on that potentially happening in the joints. We know patients with blue-collar work compared to white-collar work tend to have more bone spur formation, more spinal fusion. And we have rat models where they hung the rats up by their back feet, so they could only walk on their front paws. They're spondylitis rats, and they had all the damage in their front paws and not their back paws. So we do think trauma may be a possible trigger. Now, if you were normal and then you got the car accident and you got the spondylitis, it's really hard to prove. Yeah, maybe as a global thing, but on the individual level, hard.
Okay, so this question was for both Dr. Chan and myself. Please comment on core exercises and the 15% of patients who can be treated successfully. How much exercise would be required? Forms of exercise, ? Firstly, I hope I'm interpreting this right. I don't know that Dr. Chan was stating that these patients were cured necessarily with exercise. It was more that they are managed, they're able to manage just with exercising and not medications. And it has more to do with the spectrum of disease in individuals, because like any condition, there's a range of severity in how many symptoms you get. And so I think this is correct me if I'm wrong, that this is more to do with the individuals who are lucky to have fairly relatively minor symptoms, and as long as they stay active, they're able to manage the stiffness and discomfort that they have. Do you have anything to add to that?
No, that's right.
Okay. Okay, so in terms of how much exercise would be required, generally speaking, for all of us, the Canadian Physical Activity Guidelines for all adults for our overall health and to avoid developing chronic disease, which we know that individuals with spondylitis are at increased risk of developing osteoporosis, cardiovascular disease. To stave that off, it's recommended that not just them, but all adults do at least 150 minutes of moderate to high intensity aerobic physical activity per week. So that breaks up into roughly 30 minutes around 5 days per week. And you can do more and you get more health benefits from that. And what that means is anything, and it doesn't have to be exercise per se in the gym, it's any activity, gardening, housework, if you're like, cooking and doing a lot of like heavy stirring, anything that gets your heart rate up a little bit, gets you a little bit warm, makes you breathe faster is considered moderate level physical activity. Obviously the harder you work from there, that becomes more vigorous physical activity. So the current national guidelines are 150 minutes per week. And they also recommend that you do 2 days a week of strengthening exercises. And that doesn't necessarily mean going into the gym and working out with weights. If that's not something that you like to do, it can be something like doing an aquasize class or doing Pilates. Those are sort of the general recommendations for all adults, and they most certainly apply to particularly, I'd say, with individuals with inflammatory arthritis. Given that we are at higher risk of developing certain chronic diseases, we have to make sure we look after ourselves. It's not just for our own health and our well-being, but also for disease prevention. Exercise has also been shown to help improve mood. It's as effective as antidepressants. It can help benefit every single system in your body. So I hope that answers the question.
I don't know why I took those off. I need them to read the darn thing. Are biosimilars going to be the first to be prescribed, and only when and if these are unsuccessful will the original anti-TNFs be prescribed? If they are difficult to copy, will they be as effective and safe? Who here has heard about biosimilars? Raise your hand. Okay, so enough of you. So biosimilars, when a biologic's patent is up, a biosimilar, not a generic, a biosimilar can come in after it. Why is it not called a generic? Because biologics are made from living cells. And unlike small chemicals or things that come in pills that can kind of almost be photocopied chemically, biologics cannot. So the one that comes in after the patent is called a biosimilar. The biosimilar that is on the market in Canada and is now being listed on reimbursement, for reimbursement on formularies across the country, there's only one, and thus far it has been listed in a preferential manner in 4 provinces. 4, is that right, you guys? 4. BC was the first to list, and if your rheumatologist prescribes you infliximab Inflectra, the originator's called Remicade, in this province and 3 others, you will not get Remicade, you will get the subsequent entry biologic, or SEB. They will pay no portion of Remicade if that's what you want, if you prefer that. There's obviously quite a bit of controversy over the listing. So if you're but no one who is currently on Remicade can be switched or will be switched at this point. However, remember we talked about anticipating a problem? We're anticipating a problem. So we're watching carefully and talking to government regularly that says you cannot switch patients who are stable unless you have a lot of scientific evidence that warrants it. So, and that listing is identical in Alberta, Manitoba, and Ontario, except in Ontario, you don't need to fill out any special paperwork. just a limited use. So in other words, what us conspiracy theorists think is the government is trying to dangle the carrot. It's not as big an issue in AS, but in PSA, Remicade is certainly frequently used. It's more often used in rheumatoid arthritis. But they're dangling the carrot by putting it in a category by itself. But I will add this. They cannot force you or through policy make you go on infliximab, Inflectra, if you've been prescribed, etanercept or Enbrel or Humira or any of the others. This is simply a case between Remicade and Inflectra. So I hope that's answered the question and not confused people. If it has, I'm sorry, I'll talk to you later. Yeah.
Is there any evidence that the biosimilars are less effective?
So
It sounds scary that we're going to, people may be pushed onto it, but if it's just as good.
yeah, so the data, I was at the American College of Rheumatology meeting in November. The safety and efficacy data, the biosimilar's been on the market now for several years. Most of the data comes from European patient experience. The doctor can correct me, but there are differences in the healthcare system, but not necessarily difference in the patients. So rheumatoid arthritis is generally rheumatoid arthritis in Europe and here. But the safety and efficacy data is assuring, actually. They are looking and acting in terms of safety and efficacy in a highly similar way. You can never say the same because, again, they're living cells. But the manufacturing process is different, but similar. So there have been no huge scary monsters come out of the closet on them. Just put it that way.
The only caveat to that is that the number of studies have not been that many, and the big pharma claims that they spend a lot of money on the big trials and developing it, and that's why the price is so high. There are controversies on that, even among the economists and other pharmacy, and how much money they're actually spending on it. But anyway, the biosimilars, the price is supposed to be lesser because they don't do that many clinical trials, and there's data is extrapolated. So, for example, they've done trials on Angspond and in RA, and because safety was okay and was similar, and the efficacy was good, so that data was enough for them to approve it for psoriatic arthritis and psoriasis. So that's where we, as an organization, the rheumatology associations, in partnership with patients, are saying that's important to track these outcomes. So if we have a registry where everybody is there and we can track the data, then we'll have a real life data, and we can look for rare side effects if there are any. At this stage, there's no signal. Okay, so the next question. So maybe we'll talk about biologics at one go. I have a bunch of questions on biologics, so since we are on that topic. Okay. So if you fall, one question is, if you fail all of the biologics, is there any other options for treatment? So as we mentioned, so biologics are complex protein molecules against a particular target. So the first wave of biologics were against anti-TNF. And lots of patients have responded to it and continue to respond to it, but some do not respond or fail secondarily. Then the next wave of biologics were for at least for the ankylosing spondylitis and the IL-17 blockers are there now. And so what I'm saying is that not everybody responds to every treatment, but there are other options if the anti-TNFs fail. And if there's IL-17 now, there are other molecules coming down the pipeline. And so that's research that options are continuing to evolve. And most patients do respond to anti-TNF or anti-IL-17 molecules. The next question is, how long does biologic side effects generally last for injection site reactions, hair loss, breakage. So generally the injection site reactions are a pain, but they generally get less problematic as time goes by. But sometimes it remains persistent, and it's the most common side effect of these biologics, the injection site reactions. And if it's bothersome and problematic, it might be okay to switch to another one. There are some patients who do switch because of this problem. Not much data on the hair loss part of it. If it's severe, there are other symptoms. You might want to look for drug-induced lupus if it's an anti-TNF agent that you're on. So that's one. And then the last question is, I've been taking Humira for 3 months and I'm way worse than when I started. Do I have to wait 3 more months? So when I said that you generally wait 3 to 6 months before you make a decision to change, that's when things have improved, but not as good as it would like it to be. But if things are actually getting worse, no point waiting. It's move on. There's another question about a 13-year-old daughter who's complaining of leg pains. If it's a family member, if you have AS or PSA and a family member, the first-degree relatives, having muscle joint pain, especially joint pain, and especially if it's AS and it's an adolescent kid, it needs to be if there are bone pain, a lot of time we see patients, said they had, what do you call it, growing pains, and then you realize it's enthesitis and arthritis. So it's good get a good evaluation by a rheumatologist. A pediatric rheumatologist would be important because the risk in first degree relatives is way higher than the general population. Okay, that's the biologics.
All right. I try to lump them here. So what is the impact of spondyloarthritis on childbearing? So from a disease perspective, it doesn't tend to change. Some people get worse, some people get better, but there's no major direction, unlike in rheumatoid. Medication-wise, so NSAIDs we say stop in the last trimester, but you could continue them through. I think most women would be a bit cautious about that. Biologics, in general, we have been not encouraging, but suggesting you can continue. It seems to be a pretty safe signal. But of course, there's no randomized study where they take half the pregnant ladies and put them on drug and half on placebo. But in general, we don't tell people to stop. In other diseases too, say for Crohn's, if you flare while you're pregnant, you're going to be on high-dose prednisone, which is definitely, there's potential side effects. So in other diseases, we've seen people continue through their TNFs, and no major signal in terms of birth defects there. If you've had pain for 10 years and have only started biologics now, is that still considered early detection? No, from symptom onset, 2 to 5 years is kind of considered early detection, ideally earlier than that. But not to say that you won't have improvement. So if you have objective signs of inflammation still, if you have positive X-ray or MRI or CRP, you've still got a good chance of response. So it's a little bit less, but definitely not zero. Nutritional advice to reduce symptoms. So there's a lot on the internet there about certain anti-inflammatory diets, gluten-free, dairy-free, starch-free. There's no evidence. Not to say there's negative evidence, there's just no evidence. So in rheumatoid, there's a couple studies with fish oil and Mediterranean diet. It's kind of been equivocal. You can drink a couple liters of fish oil a day and maybe it'll make your rheumatoid better. Spondylitis, no evidence there. I've had patients who went starch-free, said my 8 out of 10 pain went to 0 out of 10, which was great. I had about one person who said that, and then I had about 20 people who tried it, didn't work, and they stopped it. And they're very restrictive diets: no rice, no bread, no potatoes, no fun. So if it were me and if I were inclined to do that, it's not unreasonable. Try it, but give a time limit and say I've done it for 3 months or so, and no benefit. Then there's no, it's probably unlikely to work at that point. Weight reduction. So this is only if you're. So the question was do you recommend weight reduction if you're not overweight to begin with? And so not really. You want to have a healthy body weight. And if you're losing body fat but you're gaining muscle, that would generally be a good thing. So yeah. Is there a difference between AS and peripheral spondyloarthritis and rheumatoid arthritis? And you have all of them. And so yes, they're different. So AS and rheumatoid arthritis are not really genetically linked. I mean, there are a few genes, but they're not strongly genetically linked. Can you have all of them? You got to be pretty unlucky. Do you have patients with both?
No.
No. We generally,
I think I had one patient.
yeah, out of I don't know how many thousand patients he's had. What causes one and not the other? Genetics, environment, and bad luck. Environmental triggers are smoking, all the things that Dr. Chandra mentioned, but the gene profile is different between the different diseases. So, what tests are best to show inflammation? If you have swelling, redness, and pain, but the CRP doesn't indicate it, so the CRP is not a particularly sensitive marker of inflammation in any of the diseases. In AS, it's 30%, so 70% of people have bad disease, but they have a normal CRP. Clinical exam for the peripheral joints is the most useful, right? Some joints are hard to assess, like the balls of the feet. Sometimes you use ultrasound and MRI, but generally, hands, wrists, elbows, knees, generally you're pretty good with clinical exam, and that's kind of your gold standard there. For the back, it would be CRP, X-ray, and MRI are probably the best tests to use to objectify the inflammation. Can one have symptoms of IBD, back pain, SI joint pain, bone spurs, psoriasis, but no changes on X-ray or MRI? Good C3-4 levels, and get a proper diagnosis for AS. So yes, you can, with the caveat being, so you do want to have some objective sign of inflammation because chronic back pain is very common in the general population. Number 2 reason to see a GP right after colds and flus. So if you look at big studies, about 20% of all people have chronic back pain, and only a small sliver of that is from ankylosing spondylitis or axial spondyloarthritis. So you could be in the camp, potentially, of having Crohn's and back pain and not having spondylitis, but certainly having Crohn's and psoriasis increase your risk. So if your X-ray, MRI, and positive B27, so that even like really skyrockets your, not skyrockets, but it really increases your risk. So it is possible that you don't have spondylitis, but your probability is getting lower and lower with all these features. So it would be X-ray, MRI, CRP. The other thing is imaging is very subjective. So you need to get a good radiologist or rheumatologist to read it. And so I'd say almost of people with definite X-ray changes in clinic, I'd say 50% of the time the radiologist read it as normal, and it's clearly abnormal. So make sure you know who's reading it. Doctor accepting patients. Yes, yeah, I do accept patients. You can.
At 7:30.
Yeah, you can find my contact information. Just Google Jonathan Chan, Artis Health. Pretty sure, if it depends on. No, I see people pretty quickly. I like to work hard. My wife complains, but it should be. It's quite fluctuant. Well, within a month, a couple of weeks, to a month. I'd think maybe about a month.
And also, Dr. Chan, they graduated 4 new rheumatologists off the last class, as I recall.
Yes, they were pumping them out like hotcakes. So, it's a golden era to be a rheumatology patient in Vancouver. I think nowhere else in the country can you have, can see a rheumatologist that quickly. So I have spondyloarthritis undifferentiated. Is that just a catch-all phrase? Is it a bit hand-wavy? Yes. So it's kind of an older term. It's kind of falling out of favor. So, we used to say people with kind of a convincing history, prolonged morning stiffness, better with activity, good NSAID response, buttock pain. That kind of got that flavor, but their x-rays are negative. Let's call that undifferentiated SPA. Nowadays, we're moving more towards, making a more firm diagnosis. Are they MRI positive, clinical diagnosis positive? So we're using this term undifferentiated SPA a lot less. So it kind of depends, do you now fit in one of these new criteria? Maybe. And if you don't, we're finding that a lot of people have, a lot of people with mechanical back pain or, like a slip disc or herniated disc, as an example, can still have inflammatory features on history. So it's possible you're in that camp too. So if someone is HLA-B27 negative, does that mean one is negative for the gene? Then how does one get the disease? So as I may have mentioned, there are over 100 genes identified, and we only test for B27 because that's the biggest driver. But there are, hypothetically, you have the other 99, or other patients, maybe you've got more of an environmental trigger. So in Crohn's patients with axial spondylitis, only 60 to 70% are B27 positive because you've got such a big environmental trigger. So there's a lot of patients who are B27 negative for various reasons. If you keep having reactions to biologics, what is the next step? CBD drops. I guess that's CBC maybe? CRP maybe? What's CBD? Oh, I see. Oh, okay.
Oh.
Yeah. Yeah. I've had patients who've tried THC and have had benefits, some not. There's just no data, and it's hard to know the effect, the response. Are people as functional? I think it's an area that we need more data on. But I've had some patients who, as I mentioned, have had good response, but others not so much. So. There's, as I was probably mentioning earlier, there's no, if you tried biologics didn't help, you could try other things too and always come back to it. It's not like an urgency like in rheumatoid.
So when you're taking, the more I read about like different drug combos, like the methotrexate.
That's not a typical combo for AS. I don't know about maybe in ankylosing spondylitis, we don't use methotrexate and Imuran. Like there's. Oh, okay. Yes. Oh, that'd be another issue. But the CBD wouldn't help your Crohn's, I would imagine. Yeah. It would have to be a case-by-case scenario, but certainly combination therapy has a slightly increased risk of infection there. So. But it would have to be, I guess, a case-by-case scenario. We could talk about that more later if you want. If a person with AS responds to NSAIDs, do you offer other options? What and why? Right now, we're basing it mostly on symptom control, so pain and stiffness. So if you're living life happy on NSAIDs, I don't think we necessarily need to progress towards a biologic. But for a lot of patients, they still have persistent symptoms that are quite bothersome despite that. And so typically it's function that we're looking after. So pain, stiffness, are they missing work? Are they not doing recreational activities they enjoy? All important things. If I stop feeling any symptoms after taking a biologic, should I stop taking the biologic? I do it talk to your rheumatologist. If you've been in remission for quite a while, there are studies looking into dose reduction, and it's in AS because the chance of it's not as anti-drug antibody driven. We often will try to decrease it, but you got to be in remission for a while. If you've been in for like 6 months, I think it's a bit too soon. 2 years is what our Toronto expert is saying. Once diagnosed, will any insurance company cover me for both NSAIDs or biologics? That I'm not sure.
Depends on the payer, depends on the plan.
Okay. You heard it from the expert, the arthritis consumer expert. Does your CRP levels correspond? What does your CRP levels correspond with, and how inflammation as it relates to AS? So some people have CRP, and that can be for them a marker of disease activity, but many people never have a positive CRP. So then you have to follow clinical symptoms. Yes?
So if your CRP stays up a bit, but your stiffness and your pain is down, is that okay?
Yeah, it can be. You'd have to look into, there are a lot of causes for a positive CRP. You've got a cold or a flu, urinary tract infection. Some people just have a positive CRP. Yeah, and it depends on, yeah. And that might be your normal too. I'm not sure how high it is. You have to divulge, but.
It wasn't there before.
Yeah. So.
Slowly
Yeah. So then you'd want to hunt down other causes. Having increased body habitus can also drive a positive CRP. Any comments?
Yeah, especially in the psoriatic world, it's also the obesity that and visceral abdominal fat that is another factor with the CRP being high. Right. No, and if your body, one thing to look at is if everything else is okay, there's no infection, is your body at ideal body weight, and if it's still high, it could indicate some subclinical inflammations. But if it's not symptomatic and you're on the appropriate dose, I would say that's your new normal.
And the last one here, I have red and dry cuticles, but not all the time. Puffy and red, it comes and goes. It's hard to say, I think we got to see it clinically before we can really comment. And I've left elbow pain. You could have arthritis, you could have enthesitis. It's a clinical diagnosis, so I think you have to be examined.
I have one last question. What is your advice on how to live with the fatigue and depression that often is a result of living with severe chronic pain? I think this is something that we can probably all relate to. It's hard. It's definitely not easy. My advice is that if you're finding that your mood is stopping you from being able to do the things that you would like to do, if you're finding you're feeling really listless, it's starting to affect your life in general, your sleep, etc., I would seek help. There's evidence for cognitive behavioral therapy being very effective for both anxiety and depression. There's an online website that has a that delivers online CBT. It's cognitive behavioral therapy. It's called moodgym.anu.edu.au. For anyone who wants to write that down. This is a resource out of the Australian National University. It's been recommended by psychiatrists that I've spoken to. moodgym.anu.edu.au. And part of that is trying to work around recognizing when you're starting to have these pattern thoughts that are not being helpful, not being productive. Whether it's the chronic pain or the depression that's driving the chronic pain, they can both feed into each other. I have to say, I'm probably a bit biased, and also through personal experience, but trying to stay active and finding something that you enjoy, that you're focused on, can also help a lot. If you're deconditioned, if you're not getting much physical activity, that actually exacerbates the symptoms. It can exacerbate joint pain in and of itself. And so trying to keep yourself active not only decreases the fatigue, but it also helps reduce your pain and help improve your function and your mobility.
I just want to add one thing. There's a local resource here at the Mary Pack, and it's social work, and you don't need a referral, which very few things in autoimmune arthritis you don't need a referral for. And you'd be surprised how effective it is to just go talk to someone who's qualified to listen. There are, lots of people that we have in our lives, and you stop sort of talking about your disease experience because you don't want to you kind of feel like you don't want to drag them down, or you're starting to sound like a nag or whatever. You might think about your own expression of disease challenge. So social work and that program is available. It is at no charge, and it is self-referral. So I would encourage all of you, if you want, to check that out. So often one of the things that is a barrier for people who have disease and are depressed, depression drives pain. So if you're in pain, you need to reflect, what has your mood been? And just know that biologically depression drives pain, and depression is almost never talked about in clinic, unfortunately, because there's so many other things to talk about, joint counts, other disease activity measures, but depression is a big one, and a lot of people struggle with it. Divorce rates are higher in autoimmune arthritis than they are in the general population, and largely because we're folks who aren't getting a chance to say what we need to say to somebody who's qualified. So
Well, thank you all very much. On behalf of SPARCC and the Canadian Spondylitis Association, I'd like to thank our presenters a great deal for taking the time to come out this evening. We especially want to thank you for taking the time to come out this evening. Your questions have been excellent, and I hope the session tonight has been informative. So on behalf of all of us, I'd like to thank our presenters. And the only closing remark I have about nutrition is that you will never get better with bad wine. Thank you all and good night. There are a couple of tables outside yet that have some brochures. If you didn't get all of the brochures, there are some people out front that have some extra brochures you may want. Thank you.